بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It is my great honor and pleasure today to introduce Professor Dr. Marcus Lanus. Professor Lanus is a great man of hematology and a great publisher and researcher in this field, especially after specialized in anesthesia and ICU. Dr. Lance is starting a fantastic journey, being a medical student in Berlin University, then specialized in anesthesia from 1997 to 2001, then continued ICU fellowship till 2004. He has a fantastic journey. Then he has more than 100 scientific and peer-reviewed papers, among which is European guidelines on perioperative bleeding, European guidelines on perioperative venous thromboembolism prophylaxis. He go to Doha from 2017 to 2022, and from January 2022 till now, he is the head of Department of Anesthesiology at Aga Khan University Hospital in Nairobi, Kenya. And really, I met him there in his place, and I am astonished by this kind humanitarian doctor. He is dealing brightly even with junior staff and even with the worker of the OR. I'm so glad and I'm so honored to have him today. I know and I do believe that he is doing his best and all of his effort to have a marvelous presentation today about coagulation and homeostasis. And he called this our special evening and amazing evening, and evening with coagulation. Thank you, Dr. Marcus, for your time and effort. Thank you to be with us today. Thank you.
Yeah, thank you very much, Professor Safa, for this warm welcome and this warm introduction. Salam alaikum to everybody who is listening. I hope you can understand me because, as we just said, English is not our own mother language. So wherever there is something not to understand, just raise your hand, and I'm very happy to re-explain or to slow down or to ever. It might be here and there a bit of complicated, but therefore we are interactive. So just say what is going about, and you will have during the ride, which is a quite long one, during the ride we will have a couple of pit stops to ask questions. And as Prof. Sava said, we have an evening on coagulation, as we called it, but it is divided into the physiology of coagulation. Then it is going a bit about diagnostics for coagulation and bleeding. And then we are going more about management of coagulation and bleeding in theaters. I try to be a bit general, so please excuse if I do not touch a very specific question, but we can discuss any specific question at any time during that presentation. Like I said, it's going first about the physiology of coagulation and a bit of pathophysiology of coagulation. And yeah, as you might know, and I'm sure you know, that coagulation is, of course, a fine balance between coagulation, anticoagulation, and fibrinolysis is in between to make this balance work. The hemostasis, as we know from medical school, we could divide into the so-called primary hemostasis and the so-called secondary hemostasis. If we look at the primary hemostasis, we mainly think about the interaction between the endothelium, the blood vessel, where there may be an injury, and then the blood cells, which are mainly then the platelets at the primary hemostasis. And this all happens at the place of injury, where first of all, there is something we call reflex vasoconstriction, just to stop the leakage of the blood. And if we look a bit at the hemostasis and hematopoiesis, then we know that they are all coming from one stem cell, but some of them are going to the left-hand side, which is then more to red cells. In between, we see the white cells, which are developing. And on the very right-hand side, this is at the moment a very interesting part, but in general, I find this also very interesting. This is the development of platelets. They go via the megakaryoblast, the megakaryocyte, and then the megakaryocyte breakup, which means that the mother cell of the platelets just splits off small particles, which we later on find back in our patient's blood and our own blood also as platelets. Platelets are found to be 150 to 350,000 per cubic milliliters, so quite a lot. And they resemble, as I said already, small fragments of the cells. Actually, they are not like erythrocytes, no real cells, as they have no nucleus, but still they have mitochondria, so they have metabolic activation, and they are also, as I said already, as you know, important in hemostasis. The picture here shows you in the above picture, you see resting platelets, and here below you see platelets once they became activated, or maybe we could also say irritated, and they spread out their fingers in order to make hemostasis happen. If we look a little bit more schematic to these tiny guys, we see that there are on their surface a lot of receptors residing. Some of them we know very well, and we sometimes in medical purposes block or use them. For example, we use the thrombin receptor to block, we use the thromboxane receptor to block by aspirin, and so forth and so forth. But this lecture is not about how we block them. This lecture is just about how they interact. So thinking about the primary hemostasis, and we just were there, I said it all starts more or less with the injury. So if we have the injury, then there is a blood vessel which has somehow a cut or another injury, where then out of the blood flow, the platelets are trying to form into the first plug in order to stop the bleeding and the leakage. I will go into more detail right now. So we can see that the platelet function is divided into different areas. Part of the function is the adhesion, then the secretion, then the so-called aggregation, and we could also see a procoagulant activity of the platelets. If you look at the adhesion, then we see that, again, on the right side, we see the vessel a little bit more focused, and then there is that injury. And on the right spot here, we see that there is some subendothelial tissue which came free due to the injury. And we see here that some collagen gets free, but also some von Willebrand factor gets here into the activity. So von Willebrand factor is actually the major part of platelet, let's say, capturing molecule, which captures them. It interacts with the glycoprotein 1b9 complex. It catches, so to say, the platelets to be sticky to that place where the injury happened. In the next step, the function of secretion, then once the platelet had been caught, again, the same picture, but a different situation. So once the platelet had been caught here in the middle, it deliberates after activation some agonists, which is thrombin, epinephrine, collagen, and others. The platelets, as you may know, they have in their contains also the so-called dense granules, which contain ATP, thromboxane, serotonin, and other substances. And in the alpha granules, they have fibrinogen, more von Willebrand factor, and so forth and so forth. So this all is then, all of a sudden, once the platelets is activated, deliberated and spit out, so to say, to activate more platelets. So this is some kind of a cascade. Then after this, it comes to patient platelet aggregation. And just to remind you that, let me go first, the secretion, the in-between situation between secretion and aggregation is the point of no return. That means once the platelets reached the moment when they get to secretion, the activation part of the platelets is gone and they cannot be reversed or be quiet or going into the resting area again. So once we are reaching here, function of aggregation, platelets continue to do their job, which means that they clot, which means they are binding to the glycoprotein 2b3a receptors, which is, of course, then interacting with the fibrinogen. And only then there is, as I said, the point of no return. Platelets stay activated and make their business. The final part is then that the pro-correlative activation will be there, which means after the platelets changed, and you saw the picture before, from a tiny round platelet, so to say, to the one with the whole fingers outside. So once this state has been reached, the platelets will not be able to go back. They interact with each other. These fingers spread out to the other friends, the other platelets. They bind each other, but they also bind prothrombin complex, and they then are actually the starting point of the plasmatic coagulation, which we come to in a couple of minutes. They start the thrombin burst, and they start later on then also to stabilize fibrin and factor 13. So this is an essential part of the coagulation, and it's very important. If we now look at the secondary hemostasis, and you know this very well, after the injury, as I told you, we could either go into an overactivation, which we sometimes see pathologically, which could lead to an occlusion of the vessel, for example, a heart attack or any other obstruction, a pulmonary embolism. We could see that the growth of the clot is somehow controlled, which means balanced, and we have just a fixation of our injury, but the blood still can flow. And it could also be, for example, in a DIC situation, that the blood is not able to to build up a stable clot, and there is still a leakage, and even more, the coagulation gets totally into disruption. Coagulation has been under the figure of under investigation since a long time. Already this gentleman, which was called Mr. Fierot in the 19th century, actually made the first practical coagulation test, which I like very much. He had a horsehair, actually, from a white horse, which he pulled through fresh blood in a glass tube. And once there was a change of color from white, of course, to red, he saw that there was some coagulation active. Of course, this is a very subtle method and it's not very specific, but at least it is some kind of an interrogation of clotting. Later on, then, of course, other people like Mr. Morawitz in the 20th century came up to describe some coagulation factors. And then this gentleman might be known to more of you, Mr. A.J. Quick, who developed then the so-called quick test, and later on also the therapy with vitamin K antagonists. And then, of course, Rappaport and his colleagues, he was the first in the 60s of the last century to describe some more coagulation factors. So all of these gentlemen were actually involved in the description of the coagulation cascade as we know it nowadays, but as we also changed a couple of years already ago. We will come to this. So if we look at what we need for the coagulation, and sorry for that busy slide, but actually these are all the factors we see in our patient's blood, or actually we assume that they are there, which begins from factor 1, which is fibrinogen. And just to draw your attention that the fibrinogen is on the very right side, you see this, very high concentrated in our patient's blood, up to 3,000 milligrams per liters, and it has a quite long plasma half-life time compared to all the others. of 90 hours compared to prothrombin, which has a half-life of 65 hours, and so forth. The shortest half-life, and I only want to point this out, is factor 7, which of course makes perfectly sense if we go later on to the cell-based model. And please keep this in your mind that factor 7 has a quite short plasma half-life time, because this is quite important. But I want also to point out that factor 6 at that moment was not assigned, and I reassigned this for us. This is a surgical suture. There is nothing more important during surgical bleeding than the surgical suture, coagulation, and maybe some burning, so it's just some electrocauterization to stop a bleeding manually. In addition to that, I added also factor 14, which is a time. Because we see frequently that once we have a patient who is difficultly to get under control, he is still a bit of oozing. If we take a bit of time, we send our surgeon maybe to take a cup of tea, rest a bit, get him calmed down. We do maybe a little of job in terms of hemodynamic stabilization. I come to this at the end of our presentation. Then bleeding stops without any other measures. So time is also, in my eyes, a very important correlation factor. The classical correlation cascade, as we all know, was presented and developed by our researchers. I just presented, and there are more than them, but this was just out of their interest in why blood is clotting. And as you know, and as we know, learned this in medical school, it has a so-called intrinsic pathway you see on the left-hand side, which is actually starting with factor 12, then factor 11, factor 9, and then going about factor 9a into the common pathway, which is factor 10, then prothrombin and fibrinogen, and of course at the end, which is important to stabilize the clot, factor 13. The extrinsic pathway, as we all remember, was the shorter pathway, which was always started with factor 7a, and then it went across directly factor 10a, prothrombin, and fibrinogen. As you may know, this waterfall cascade was sufficient to understand how those clotting factors interact, but there were some questions still left over which we could not really explain to us. So the shortcomings of that model were actually that factor 12 deficiency, which every now and then occurs, shows us a prolonged APTT in the laboratory. Of course it does, but clinically it is not associated with a bleeding. So in that sense, there is something missing in our thinking. In addition to that, HMK or PK deficiency does lead to a bleeding, although it is not very much involved in the classical understanding of coagulation, because the Hagemann factor, which is the HMK, is actually some kind of side stream of coagulation, and it has never been really introduced into the coagulation factor cascade. Similarly, the factor 11 deficiency could present quite various, either into low bleeding tendency or even into a clotting tendency. Still, there is an APTT prolongation frequently seen. And then on the other side, and you will know this much better than me, that the hemophilias, as we know them, the factor 8 or the factor 9 deficiencies, are not one-to-one transferable or translatable in terms of bleeding tendency or the clinical phenotype, which means that the level of their concentration in the blood or the plasma of our patients does not necessarily reflect their tendency to bleed, which is, of course, a bit of a pity if we go to this clinically. So therefore, not only therefore, but this as a consequence, researchers came up with a different model, which you may know because it's meanwhile already 20 years in the air, or more than 20 years. It's a so-called cell-based correlation model. which explains and helps us a bit to understand why the just mentioned shortcomings are actually not shortcomings, but are actually different understandings of a system. So if you look at it, and let me start at the left-hand side here at the initiation. It looks a bit complicated, but it's not much more complicated than the other cascade. So if we look at it here on the left-hand side, then we see that it all needs a tissue factor bearing cell, as it is described in the original publication. So here tissue factor is our core. It could be an endothelial cell, it could be a white cell. Monocytes, for example, have also the capacity to present tissue factor. It could also be platelets, as you see here below. So in the initiation period, when we have the vessel injury, there will be some tissue factor coming free, as I told earlier. This tissue factor is able to activate tiny amounts of factor 7 to factor 7A. Now, factor 7A immediately, as you know from the classical understanding of the coagulation, interacts with factor 10 by having also factor 5 there, produces out of prothrombin tiny amounts of thrombin, only tiny amounts. We would not see that this is enough for clotting, but this is just enough to kick off the so-called amplification. So in other words, the classical understanding of the waterfall cascade does not include the so-called intrinsic pathway, but more or less focuses on the extrinsic pathway, if you want it like this. If we now are sitting here at the right upper side, the amplification pathway, then we see that the tiny amount of thrombin are used now to go further to activate more factor 5 to factor 5A. And now factor 5A, the huge part of it comes out of our platelets. And you know that the platelets are essential in the primary hemostasis. So again, we need first the primary hemostasis to support the secondary hemostasis. Once this is kicked off, it goes its way either with or either without the so-called Josso loop. And I go to this a bit more detail. We have here on the right upper side an amplification loop, which is running across factor 8 and or running across factor 11. So both of them could contribute actively to amplification of this area here in addition. But mainly we need the activation of the tiny amounts of thrombin to factor 5, factor 5A. While this is happening, we see this here in the propagation phase, that then we kick off factor 9, we kick off factor 11 again, we come to factor 10. And this is the most important clue, because factor 5, together with those factors, will form out of our prothrombin what we call thrombin burst. So then it really produces large amounts of thrombin, which are able to convert fibrinogen into fibrin, which will, of course, add, as you know, the mesh to form a stable clot. So this is actually the major message, that we do not necessarily need the intrinsic pathway, as we know from the waterfall cascade, and we may not always need the total amount of factor 9 and factor 8. If we look at the amplification cascade only, and this is only a different scheme, we're running from upwards, as you say, tissue factor 7A will be able to activate factor 10A and factor 5A directly, will be able to activate thrombin, and by this we get fibrin activated out of fibrinogen. Then there is, as I said, the enhancing moment via factor 8 and or factor 9, and this is called the Josso loop, which could, if it's available, enhance that process. Either that factor 7A and tissue factor activate factor 9, or that by the thrombin area here, the factor 8 will be activated and amplify actually the factor 10A production. So in other words, this at least partially explains why the level of factor 9 and factor 8 cannot 100% predict whether a patient will bleed or not. Because if our body or the body of the patient compensated with higher levels of other coagulation factors, it could be overruled, so still be in balance. Having said that, I come to something we don't want, the uncontrolled clotting. And as we don't want this, and as I said this already before, there must be something to dissolve the clot or to inhibit the clot. Coming back to our coagulation cascade, and please excuse these difficult schemes. Again, it is tissue factor, factor 7A, factor 10 in the middle, together with factor 5, forming thrombin, forming fibrinogen, outer fibrinogen fibrin, and here would be then factor 13. We know that there are some natural anticoagulants in our body to control that. We call it antithrombin. We know that protein C, mostly together with protein S, I didn't mention it here, counteract some of those clotting factors. And at the very beginning, and this is still under good investigation to develop anticoagulants, tissue factor pathway inhibitor, TFPI, which is also essential to inhibit the interaction between factor 7A and tissue factor. So in other words, to inhibit the coagulation at the very start. So those 3, or /4, if you get protein S in between here, those 3 to 4 molecules are our natural clotting inhibitors. But if the clot grows too strong and too quickly, we have also a fibrinolytic system, which means that at the very moment, the clot needs to be dissolved in order to give way for our blood. This is called, as you know, plasmin, the major part of it. Plasmin derives from plasminogen. It will then directly interact with fibrinogen / fibrin, will chop fibrinogen or fibrin, the clot, into fibrin degradation products, FDPs. And there is an interaction with thrombin as well. So thrombin is not only a natural procoagulant, it supports also the fibrinolytic system. As some kind of interactive activators, we have the TPA, the tissue-derived plasminogen activator, and the UPA, which is the urine-derived plasminogen activator. Both are molecules. One is natural, one is less natural, which will be used for therapeutic purposes, which could facilitate a quicker transition from plasminogen into plasmin. Then, as a natural inhibitor of that system, interestingly, every pro has also a con, is the alpha-2 antiplasmin. And another inhibitor is the so-called TAVI, the tissue factor activated fibrinolysis inhibitor. And this is again something which, the thrombin activated fibrinolysis inhibitor, which is directly via thrombin interacting and actually inhibiting the fibrinolysis, but also interacting with the production of the clot. So it seems a bit complicated, but at the end, it is a tiny balance between forming a clot, keeping the clot at the area where it should be there under control, which are our natural anticoagulants. And then after the lesion has been healed or sealed, let's say it this way, there is some dissolving mechanism, which is a fibrinolytic system. And parts of this are also used for therapeutic purposes. I will not go into detail of this today. So let me come and maybe get a little bit about coagulopathies, as you allow. If there are questions right now, raise your hand, raise your voice, and we could have an interaction. Otherwise, we could keep the discussion at the end of that very moment of this presentation. So as you see here, there is a huge amount of different activations or situations playing across a coagulopathy, which is, of course, bleeding and thrombotic activation, the GIC or TIC, which is trauma-induced coagulopathy, then vascular activity or vascular changes, then the thrombocyte function, as I indicated already a bit, then something called hyperfibrinolysis, factor deficiencies or inhibitors. Some are natural, so inherited, some are also acquired, and we talk more about the acquired. Then metabolic, of course, activities. Then something I called the innocent bystanders, which I will explain during that ride. And of course, as you all know, the drug-induced coagulopathy. Interestingly, and this is important for us as practitioners, we should distinguish between the phenotype, which could be either a bleeding diathesis or a thrombophilia. And sometimes, in some phenomena, it is even both a bleeding and a thrombophilia diathesis, which is a bit controversial, but I try to explain this once we reach there. So some older studies, and this is a study already nearly 20 years old, could actually show us, and this is a very nice study I love very much from Kroshnelny and co. They looked at about 5,500 patients, and they wanted to see why those patients have a bleeding diathesis. So they asked them questions about their normal behavior, if they bleed or not, if they develop quickly some hematomas, if they have some gum bleeding after they do a toothbrush, and so forth and so forth. And they came out that about 80% to 90% were explainable with their bleeding tendencies, but about 10 to 12% had not very much explainable bleeding tendencies. They did a little bit more investigations in the ones who were then at that level, and they looked at coagulation factors, and some had an abnormal screening, some had acquired bleeding diathesis, and many of them had a drug-induced bleeding diathesis. And of course, this may be nowadays even more, as we know that our doctors in hematology and in cardiology, but also in vascular medicine, use a lot of anticoagulants or antiplatelet inhibitors. So if you see here at that scheme, many patients had some acquired, like for example, some metabolic, like uremia associated problems, but then the major part, again, drug-induced, which is some NSAIDs, and a very low part, hereditary, which were not yet detected. So this is the major part of the bleeding tendencies which are seen in the patients. However, we did a little bit more closer look at them. And again, excuses for the busy slide. I will not go into detail, but we took actually, if you go back, a look at these 10% again, and we screened in our pre-anesthesia ambulance, we screened patients with abnormal results in a questionnaire on bleeding. And it came actually out that most of them did not really have a single factor deficiency. Some of them had a mixture of slight lower factor, but a combination of one or two factors. And some of them had actually only something which is a thrombopathy, but essentially it was not very well explained. So it still stays uncertain. And therefore, I don't go into detail. If you want, you could look at Minka's publication, which actually comes to the conclusion that it is still not well explained why 10% of the patients giving us a positive result in a bleeding questionnaire are not laboratory-wise explainable why they bleed. And still, this is a very interesting fact, and I would like to dive more into detail to see this. Anyhow, I said already that a lot of those bleeding tendencies are drug-associated, which means that our colleagues, but maybe also we, use deliberately, therapeutically, antiplatelet drugs or antithrombotic therapy, but also pain medicines, as you know, the NSAIDs, affect, at least a good part of them, coagulation/platelet function. Sometimes this is unwillingly, unwanted as a side effect, as I call it. For example, the SSRIs, so the antidepressants of the newer generations, then antibiotics, phosphodiesterase inhibitors, opioids, sometimes the abuse, some kind of herbs and homeopathics may play across. Particularly, and this is sometimes not really realized if we are now considering anesthesia again, and we find ourselves in the anesthesia pre-assessment clinics, we should also ask our patients about if they take any kind of special herbs or special homeopathics, particularly those Chinese medicines, sometimes can influence coagulation quite efficiently without the patient knowing this. So this could bring him or her into problems during surgery. Sometimes acquired coagulopathy is malignancy associated, and you all know that in the most common parts is it presenting as a thrombotic complication, and I don't go into this detail right now because this would take us another 3 hours. But sometimes it's also going into a bleeding tendency due to gammopathies, due to any other fibrin problems, autoantibodies against platelets, autoantibodies against coagulation factors, and I come to this in one of the next slides. So it could also turn out that a malignancy-associated coagulopathy is not always translating into a thrombotic state. If we look a bit at the differentiation between primary and secondary, as I called it in the beginning, we see that sometimes our patients present with a thrombopenia, which could be either due to decreased platelet production or an increased consumption. Both could be then due to their basic underlying disease, which could be a malignancy, as I said, drug association, but also due to infection, or, as this is the Professor Safa's major part, during pregnancy, so gestational, and many more situations. But a thrombopathy could also be, as you know, and this is somehow a little bit more mysterious because it is very difficult to figure out if the platelets are not well functioning, but they are well in the numbers. So this we call a thrombopathy, which could be induced by an extracorporeal circulation, for example, in cardiac surgery, but also due to dialysis. It could be, again, due to drugs, due to some kind of malignancies like myelodysplastic or metabolic, for example, liver issues or renal issues. Again, looking at this is only a short look out to primary hemostasis defects. Vasculopathies are sometimes underestimated and even not very well evaluated by us as anesthetists because we just don't think this will affect. But there are so-called gammopathies, which could derive from vasculopathies, which could have a combined issue, some kind like you see here on the picture, which could be some peripheral microvascular occlusion, and at the same time, a general bleeding tendency, as I said. That could be a gammopathy, it could be a Moscovich microangiopathy or an HUS, but also a TTP, which is essentially an ADAMS13 deficiency. And ADAMS13, as you may know, is the natural counterplayer of von Willebrand factor, which means that once there is a problem with too little factor 13, ADAMS13, this means that then von Willebrand factor, particularly the bigger molecules, will accumulate, stimulating coagulation much more. And this is the reason why they have also those microvascular occlusions. Anyhow, interesting. But we see also sometimes a so-called acquired von Willebrand factor syndrome. It's about 20%, so it's quite a lot of the von Willebrand factor patients we see, and that had a bit of multiple origins. Mostly, we find them in medical reasons, so 50% in hematological disease, which will primarily not even affect us as anesthetists. But also we see them in the cardiovascular disease, and therefore I mentioned it here. It could be due to autoantibodies by neoplasms. It could be due to absorptions of von Willebrand factor, due to shear stress, again, in combination with neoplasm. It could be, as I said already, due to an enhanced proteolysis of von Willebrand factor, so more ADAMS13 or other molecules. some, like, for example, antibiotics or uremia, but also an intense shear stress. For example, the cardiac anesthetist under us will know that if there is, for example, an aortic stenosis, then the chance that the thrombin factor is not as effective as in other patients is higher due to that mechanism, and also some decreased synthesis, for example, in thyroid dysfunction. Treatment is we, of course, treat the underlying disease. We could, as we see the patient in the acute bleeding, try to give them some GDIVP, or you call it minerine or desmopressin in 0.2 to 0.5 mics per kg to stimulate the deliberation of thrombin factor out of the endothelium. I think we come to this a little later in the presentation. And we could also simply replace it either by concentrate, which is more sophisticated. It's a factor 8, factor 5 thrombin concentrate. Cryoprecipitate has also a lot of thrombin factor in there, and we could also use that. Let me now come to another coagulopathy, aside of the primary, which is a trauma-induced coagulopathy. And this is quite complex, and I will only touch on a couple of parts of this because otherwise we would be here for hours. And let me see if this figure comes up. Yes, it comes up, but I want to go to this, which is much more even complicated than the one I showed you before. But I will try to guide you through this. So if we start here at the very top, there is some tissue injury. And this tissue injury will go mostly together with some blood loss. So hyperperfusion or shock will come here. Both of them could introduce hypoxia due to malperfusion. Epinephrine, as a natural response of our system, could be deliberated. And of course, there will be tissue factor coming out. And of course, epinephrine and tissue factor exposure will cause or stimulate some coagulation. Likewise, the tissue injury itself will cause some deliberation of histones, which are very procoagulative, but also other polyphosphates and HMGB1, which is also procoagulative. As that, the endothelium will be activated, will stimulate on the left-hand side clotting, which goes then into a very complex situation. I will touch on that very left-hand side in the next slide, so don't, or in the over next slide, sorry. So don't be confused. But we will also see here some platelet activation. This will interact with our immune cells by the complement system. And at the very end, the platelets will not even only be activated, but some, in particular, this is a malfunction in our trauma-induced coagulopathy, will end up into some kind of platelet dysfunction. And this platelet dysfunction could cause or support the trauma-induced coagulopathy. In addition to that, we have, due to that endothelial activation, some fibrinolytic activity, which comes into play. And as I said before, we will come to the more detail here. We will produce a lot of thrombin, we will consume factors, and at the end of the day, we have a problem between forming a stable clot and having a good platelet activity, which could have more production of fibrin. So at the end, this trauma-induced coagulopathy is a very complex situation. And don't get shocked about this. I only want to show you on a couple of things here that the platelets are also a culprit. The platelets, if we go from the right upper side to the lower side, maybe, we could see here on the upper side, we see this is the endothelium. We see here the thrombin factor, as I told you earlier. The platelets are getting stuck to that thrombin factor. There is Adams 13, which could chop the thrombin factor into smaller areas. Once the thrombin factor is still activated, it could catch the platelets, get them activated at the locus of the injury. Platelets will then spit out a lot of activators, among which also some activators of the immune system. They will also form the primary clot, catching, as I said to you, more red cells, plasma factors activate the clotting. And this is something where it turns here to pathologic areas. Once we come our patients into a shock situation, the upper areas of the endothelium, and this is why endothelium is so essential into the clotting system, will shed off the so-called glycocalyx, which is actually only a small layer of, if you want it like this, glucose proteins. They will be shed off, and those are actually protecting the endothelium. So once they are out, this introduces the leakage into the tissue, which produces, as we see it in our patients, the edema forming, and then an unnatural overstimulation of microvascular clotting. And at the same moment, as I said, once the platelets are activated, and now I come to the very left downside here, platelets get activated, they interact, but they could also be overactivated, coming to, as I said to you, the malactivation, which means that they form some kind of balloons instead of those nice sticky platelets, so they are not very well functioning. So at the end, already the primary hemostasis and the endothelium are affected in the phenomenon we see in the trauma-induced coagulopathy. And now it gets a bit easier, so you can breathe again. This is now coming to the plasmatic coagulation. And as I told you, it runs all over factor 7a, factor 9, factor 10 then essentially, forming a lot of thrombin, forming a lot of fibrin. This is how our coagulation system works in the current understanding. But if we look at the endothelium, and I told you already, endothelium is very essential in the interaction with the coagulation system. It keeps coagulation system a bit under control. Our protein C gets activated due to the endothelium lesion, due to the malperfusion. And as you know, activated protein C is one of our natural coagulation inhibitors. So it will inhibit factor 8, factor 5, and by this, the amplification of our coagulation. At the same time, there will be more interaction with thrombin, thrombomodulin, and this results into more plasminogen activator inhibitor 1, to be honest. In other words, we have here some interaction with our fibrinolysis system. There will be more TPA. We will be more degrading our clots, which are less stable. So in other words, the trauma-induced coagulopathy is having effect on the endothelium, is having effect on our platelets, but the very important thing here is that we have a lesser stable thrombus because of the protein C and protein S activation, and we will have an increased fibrinolysis, which means the clot will be quicker resolved. And this is why the trauma patients, if they come into a shock, have higher degrees of fibrinolysis and bleeding. And we see this also in our ROTEMs, the viscoelastic tests. We have here an example without any kind of stimulation of the fibrinolysis on the very left-hand side. In the middle and towards the right, we have much more concentration of a fibrinolytic, of tissue factor plasma activator, TPA, and we see that particularly the clotting time, so the start of the clotting is inhibited, but also the propagation and amplification is an issue. So looking at our pregnant ladies, because I told you I would try to cover a bit of all. If we look at our pregnant ladies, we know that coagulation is changed here as well. We know that the bodies of the women are preparing for the delivery. They are preparing in a way that the blood volume will increase by about 40%, but this is more or less fluid, as the red cell mass increases not at the same pace, so only by 25%, which leads in about 30% of the ladies to an anemia due to that dilution. And this is what we see. And on the other hand, in the plasma of the pregnant ladies, a lot of things change. Some and many of the coagulation factors increase their levels, which particularly is true for fibrinogen, but also for von Willebrand factor, factor 7, factor 8, factor 9, and factor 10 increase, but also some of those natural inhibitors and lysis factors increase. And something I didn't touch on yet, the microparticles, which are a little bit badly defined particles, because some of them come from platelets, some of them, come from red cells, some of them even come from endothelium. They are procoagulant and they also increase. What decreases is sometimes the thrombocytes, or they may stay the same. Protein S and TPA decreases, and some of these factors stay unchanged. But as a result, in all, it results in a sum called hypercoagulopathy. And this is not bad, because if you remember that our ladies, once they are under delivery, they will, of course, lose some blood, and this is actually a preparation for the blood loss. Particularly, we see this in the fibrinogen levels, and this is, again, old knowledge already, that the levels of fibrinogen are increasing during the pregnancy. And this is from the left-hand side in the non-pregnant controls. In the first trimester, second trimester, and third trimester, we see a gradual increase in the fibrinogen amount. And this is not for nothing. It is to prepare the pregnant ladies for delivery. Again, as I said already, blood volume increases, plasma volume increases, and red cell volume does not catch up totally, which makes ladies a little bit anemic, but at the same time hypercoagulative, as we see here in our ROTEM. Losing a word about cardiac coagulopathy, and then I will stick to some complicated, leave it like this from complicated coagulopathies. We know that cardiac surgery affects the coagulation massively. Partially, it is due to the hemodilution, because we have, of course, the extracorporeal circulation and the priming volume, which is in some cases up to 1.8 liters. So this is a lot if you compare this to the volume of the patient. Then, of course, there is some blood loss, but there's also consumption of factors due to blood loss, but also due to other situations. I come in the next slide to this. Platelets may be activated or consumed, but also there will be an increased fibrinolysis, which will contribute later on then to the system. And then there is something we do as doctors, which is some intentional anticoagulation, mostly done by UFH, which is unfractionated heparin. Bringing this to a more easier digestible scheme, let me show you this one, which is actually nothing else than we have here the patient's vascular system on the upper side, and then that blood will be drained into our extracorporeal circulation. Part of that blood, or before it comes to that circulation, it goes into the venous reservoir, which is actually a bit of a pool of activated blood, because the blood is already stimulated due to the suctioning, due to the mixing, due to the contact with the non-endothelialized tubings. So then tissue factor will be exposed, but also fibrinogen will be exposed, and the whole tubings here will be covered by albumin, but also by fibrinogen. That is one reason why fibrinogen goes down during cardiac surgery. In the circuit itself, then, we see some leukocyte activation. Partially it happened already due to suctioning, due to the trauma. And we see also some contact activation due to the non-endothelialized system. So here we see that the classical thinking of the contact activation cascade, so the intrinsic pathway plays a role. Factor 12 and then also bradykinin plays a role. This all will be then redispensed into our patients, activating the TPA, so the fibrinolysis will be more activated in our patients. And thrombin, due to the tissue factor which comes free, will be more activated, and this all will activate platelets. And as this is an ongoing circuit process, it will roll on and continue to consume factors, continue to activate platelets and to consume platelets, which contributes to the cardiac surgery induced coagulation activation. I don't want to go into more detail, just as it is late Saturday evening, and I don't want to confuse you more, but those three principles of acquired coagulopathy are quite important to understand why and how we should tackle our patients' bleedings. So let us come a bit to some secondary hemostasis problems, which we sometimes see in the general population, or particularly in our ICU patients. We see every now and then some so-called inhibitors. Principally, the body could form inhibitors against all kinds of coagulation factors, but mostly we see factor VIII and von Willebrand factor inhibitors. Factor VIII and factor IX, because those are the hemophilia proteins, and those are frequently replenished by unnatural or not human molecules, which then cause some kind of inhibitor forming, and von Willebrand factor due to the natural disease, underlying disease. The typical presentation will be a sudden spontaneous bleeding, but also a prolongation in some laboratory tests. And I only want, and this is how it might present in our ICU patients, huge hematomas, which there is no explanation for, and some hematuria, which may also not be explained due to other reasons. The easiest way, if we see this, to diagnose, and I want to touch on diagnosis here quickly because it's a side stream, is that we just see some abnormalities in our standard tests, which may be the PT or APTT. If everything is normal, we are happy, everything might be normal. So then we only should be concerned maybe about factor, von Willebrand factor, but normally we should be okay. If we see a prolonged APTT, we could think about some factor 12, factor 8, 9 inhibitors. Ideally, we should then do, or the lab should then do a mixing study, which means they take the sample or the plasma of our patient and mix it to the plasma of a healthy patient with normal results and see whether the result normalizes or not. If the result normalizes, then this means that, or tendency more goes to normal, it means that there is a deficiency. If it does not normalize, then it means that there is an inhibitor, which inhibits also the donor, the healthy person's coagulation factors, so that we get still some abnormal results. And here's only one example of a factor VIII deficiency or inhibitor, which was later on then turned out to be, it comes out quite frequently. It could have mild forms. It could also have some heavy forms that we all of a sudden see patients with heavy bleedings. And we could also detect this on bedside tests, because this might be a normal individual, as you see here. Believe me, I will come to this later. This is a normal result, more or less. And this might be a mild hemophilia. This might be a severe, where the coagulation never starts because it stays here a green line, which means coagulation will never be activated. And this could be then, of course, also monitored once we are treating our patients. And this is something we did when I had a patient back in Maastricht, where I was on the ICU. We had a patient developing a factor 7 inhibitor. Sorry for the title, is it wrong? A factor 7 inhibitor. And we saw only in one result, namely in the INTEM, that there was a prolongation in the style of coagulation. And if you look at the rest of the clotting, which is displayed here, and I will explain this later on again, this looks quite normal, as this looks normal, and this looks normal, rather a bit overcompensated. But the clotting never starts. And this was actually, the patient was presenting with some abnormal bleeding, although there were no other reasons for the bleeding, and he had never had a history of bleeding. Then we treated him with factor 7A, and we saw that this normalized a bit. If you compare the green line here with the green line here, and the numbers here, the CT, which is actually reflecting that green line, you see this is shorter than this. And this is during treatment. So in other words, the patient at the left-hand side here was clinically not bleeding anymore, and he was under treatment for his inhibitor. So it overruled his inhibitor by giving him factor VIIa. What we see sometimes, and I only bring this because it's at the moment very hip, to talk about factor 13. A factor 13 deficiency every now and then is seen. People think it might be due to decreased production, increased consumption, and so prolonged operations, particularly on the bony area. So spine surgery is very much involved in here, may lead to consumption. But there also are inhibitors available and known here in that area, which could prevent the factor 13 activation. Tricky is that we don't see any abnormality in our tests, and I come to this in the second part of that presentation. And it could lead to a delayed but excessive bleeding. So the first instance, everything may be normal and nice, but then there will be some microvascular bleeding, and this will be prolonged and excessive and not rather be stoppable. There are some risk factors like medication, some are autoimmune associated, and some are simply unknown, like I said. Again, the mixing test is one of the very much supported test here. And of course, treatment may be, of course, surgical to control the bleeding surgically, but also if we have a chance, and we know this, to reduce the inhibitor, which is not part of that talk. And finally, to confuse you a bit more, we all know that there is the so-called DIC, the disseminated intravascular coagulation, but this disease has not only one phase, actually it has a phase of the so-called bleeding type, then the phase of the organ failure type, and the phase of the massive bleeding, and finally the asymptomatic type. Essentially, these are 4 presentations of one and the same disease, so we could be very much misled. And interestingly, as I said, the bleeding and the massive bleeding times quickly run into a bleeding situation where a patient is uncontrolled bleeding, while the asymptomatic type stays chronically due to a chronic consumption, asymptomatic, but once the patient or the coagulation system is challenged by surgery, for example, the patient may bleed dramatically. And the organ failure type is something we may see more frequently in the ICU, that it leads to microclots, and then the patient develops some kind of organ dysfunction, particularly kidney, but also other dysfunctions. The diagnosis is quite complicated and quite difficult. There are a lot of measurements we could do, like the PT, the D-dimers, the fibrinogen levels, platelet count, and so forth, and so forth. Essentially, there are some questionnaires we could tick off, and there are good examples for this already long time known. And then it could lead us to some kind of bleeding, therapeutic trial. But I don't want to confuse, so let's just go over it. The little brother of the DIC, and frequently misinterpreted with the DIC, is the hyperfibrinolysis, where is certainly an overlap between DIC and the trauma-induced coagulopathy. It is associated with a massive transfusion, but also with plasma, overwhelming plasma infusion. So then we have a dilution of alpha-2 antiplasmin inhibitor, but also we see a decreased degradation of plasminogen activators, and it could be induced by asphyxia and by CPR. There are meanwhile a couple of studies out where we see that the hyperfibrinolysis is induced by drowning, for example, so different and specific situations, and this is only one. There the investigators looked at drowning patients and non-drowning patients, and they compared them. And if you look at this here, the D-dimers are massively high here. Then the score of the DIC is massively increased here. but also lactate is equally more or less, so that is something which is a little bit comparable. So, and our laboratory results, the APT is highly abnormal. So the drowning cohort here was showing some kind of hyperfibrinolysis, most already triggered by the hypoxia, which could cause this hyperfibrinolysis. And again, it is a sliding scale between DIC, hyperfibrinolysis, and it is a huge overlap also towards trauma-induced coagulopathy. To confuse you a bit more, the secondary hematostasis may be also cross-playing. Like we all know, the renal dysfunction due to uremia, but also to low erythropoietin could play a role. The liver dysfunction, as the liver is the major part of the factor producing centers, could play across. And it could also be that the liver produces simply dysfunctional factors, like in dysfibrinogenemia, for example. And in metabolic states like diabetes mellitus, we see that the platelets sometimes are hyperreactive, which leads to a thrombotic state. But also we see that insulin has some kind of pleiotropic effects which could play across the correlation. Again, I don't go into much detail here because this would lead us to too much discussion and confusion, as I think it is a heavy load already by now. I want to have a bit of a moment stand still at the innocent bystanders. We all know them. This is the dilution, this is the acidosis, and this is the hypothermia. And we know that coagulation, as it is an interplay between different enzymes, hemodilution plays a role. And we see this here again, a classical study already a couple of years old. If we dilute our patients and we measure with saline or HES products, then we see that the PT gets prolonged, but also if we measure the factors in the system, we see that the factors according to their dilution, of course, drop. And this is, of course, only due to dilution. And this is more or less equal if you compare saline to HES. And this is the interesting part of this study, that is another innocent bystander. Because if we look then at the APT, again, we see that at some moment, it turns that dilution of 60%, it quickly turns into a hypocoagulation. And this is a bit more outspoken in the HES, but not very much. And similarly, dilution is, as I showed you before, quite well understandable due to the volume effect. But if you look at the viscoelastic test, here it was an example with the ROTEM, then we see that again, at around 60%, those tests drop quite heavily. Likewise, the fibrinogen concentration drops, as we saw before. But if you look at the HES products, it drops a little bit more dramatically than it would be if we only use saline or crystalloids to give to our patients. This should remind us that HES also has an effect on coagulation. And I think everybody knows this, meanwhile, that there is a certain effect on platelet coagulation factor interaction. We know also that acidosis plays a role in coagulation. Acidosis is mainly to find as a result of shock ischemia in our trauma patients, but also in other bleeding patients. It could also be a result of infusion of too much unbalanced crystalloids, and I only want to point out the chloride here. But it could also be due to massive transfusion of red packet cells, because due to their preservation, there is some acidity in, and the RBCs have an acidity between 6.7 and 6.8 pH. So if we transfuse too much of them, the patient could be coming into an acidotic state. Interestingly, and this is again old knowledge, if we simply now use a buffer, it will not totally reverse that coagulopathy. So the magic is we should actually restore perfusion by our attempts to resuscitate the patient. This comes at the end of the presentation, so keep awake. Then, even worse is the combination of this. And you know this because we all talked about the lethal triad of trauma, which you know. So if we combine hypothermia, or simple hypothermia on itself, gives effects on the platelets, but also on the coagulation. And for the sake of time, let me quickly go to the next slide, which means the combination of hypothermia and acidosis. And here again, a very nice experiment, again with the viscoelastic test. Daniel Dirkman and his colleagues did here an experiment where they only exposed different samples to low temperature, but also then to different pHs. This is only one pH. So here you see clearly that there is, of course, a different level, but you see also that the pH is different. So the quarter here is still giving us some more stable clots, shorter times, and here more stable clots. But if we now do a low temperature and a low pH, the stability, but also particularly the clot forming, is inhibited. So this is actually the combination of two factors, which might be interesting to know. Then, as we know all, anemia is a factor also for bleeding, for clotting. Red cells support coagulation, which means that we see this if there is a 15% decrease in hematocrit, there is a 60% increase in the bleeding time. It has a certain platelet effect. Thrombin generation will be lesser, and we see the bleeding time, but also the CFT, the clot formation time. So the amplification of the clot formation has received a hit. And partially, this is explained by the red cells in cell because they have receptors interacting with the clotting. But partially, this is purely mechanically, as explained here, because if we consider this as a vessel, and the red column here, pressing from the left-hand side, is flowing to that vessel, we see that particularly the small particles in our blood, which are the platelets, will be pressed outside, which means they will get easily into contact with the endothelium or the injury. And as I told you in the very beginning of our presentation, once there's an injury, platelets will get stick to that injury, so clotting will be starting. So as you could imagine, if those bigger parts of the cellular structure in our blood are not there anymore, then the platelets will be getting pushed to a lesser degree to the endothelium. So this interaction will be lesser outspoken. So this is one of the explanations why anemia contributes to lesser coagulation. To give you a brief, I would like to come to some kind of a conclusion of the first part of our presentation tonight. And this is not concluding everything, as you see. So the major part of the bleeding tendencies we see as anesthetists is drug-induced, at least if you look at the primary hemostasis. But also infections, neoplasms, and metabolic and mechanical factors play a role. If we look at the secondary hemostasis, and this is not totally true because von Willebrand factor is actually the interplay between secondary and primary hemostasis, then we see that this is also frequently seen. So acquired von Willebrand factor problem is also frequently found. Factor inhibitors we touched on, we see sometimes in the ICU, but we could also see this in our clinical patients for surgery. We touched a bit about DIC and the different phenotypes, which could be a problem on ICU, and the trauma-induced coagulopathy, which we see, of course, in more traumatic patients. And we discussed about the platelet dysfunction, which are the major players in this, but also endothelial dysfunction, and at some stage then also the problems with the factors, which derive then a less stable clot, which is easier to dissolve. We quickly touched on the metabolic aspects of coagulation, which means due to diabetes, liver problems, or renal problems, we have influences on the coagulation. And finally, I try to go a bit about the innocent bystanders, as I call them, the dilution, the effects of the pH. I didn't touch on the pH and the effects of the electrolytes, but also the temperature has some effect. With this, I would like to give you a chance to breathe, to give you a chance to ask a couple of questions before we go over to the diagnosis part. I hope it was not too much confusing and not too extensive.
Yeah. Thank you, Dr. Marcus, for this distinguished and highly informative lecture. Now we will have a break, but this break not for coffee or tea. It is only for questions. So we are waiting for your question from the floor. Anyone have a question, please, you can raise your hand and directly discuss with Dr. Marcus, or put down your question in chat box. I know that you have a very heavy meal, and
I know it was not easy to digest, and this on a Saturday evening.
But really, Dr. Marcus is very clear and very informative, and you put it in a very simple and palatable way. Thank you for your huge effort.
No problem. Very welcome.
Thank you. Any question from the floor? So I have a comment, Dr. Marcus. I will start until they are prepared to deliver their questions. During the slides, you discussed the slides about the initiation, propagation, and amplification of coagulation cascade. You mentioned factor 5 is an essential step in all this process.
Right.
Yes, but many times we don't concentrate on factor 5 deficiency or factor 5 transfusion, as always we mention factor 12, factor 8, factor 7, and we have factor 7 concentrate sometimes transfused empirically for the unpredictable and uncontrolled bleeding, even with all the hazard around this factor. Why factor 5 not have the propaganda like factor 7?
Yeah, that's a very good question. Essentially, we use a lot of factor 5 without knowing, because whenever we transfuse platelets, we transfuse at the same moment factor 5, because platelets contain a lot of factor 5.
Yes.
So once we infuse platelet concentrates, we give to our patients a lot of factor 5, unknowing and unwillingly, actually. But this may be also the magic about platelet transfusion, why platelet transfusion stops bleeding. I don't know, but at the end of the day, factor 5, the major part of factor 5 is located in the platelets.
Yeah, yes. So it have the same half-life as the platelet and the same temperature. Should we preserve a platelet at 24 degrees centigrade? This is the same for factor 5. It doesn't destroy or have any difference in half-life with platelet.
Not really. If we look at the platelet function, and we did a couple of studies on this because I was practically very much interested if we may squeeze and if we may warm up our platelet concentrates. It does not affect platelet function, and it does not really affect the pro-coagulative effect of platelets. And if you are aware about the current literature, there are a lot of investigations going on to preserve platelets by cold storage. So in contrast to what we do since many, many years, which means letting the platelets rest on this moving plate on room temperature. Meanwhile, it is able, or it is possible to store platelets at 4 degrees without them losing function, but having them available for up to 30 days, I think. And we could even, and this is investigation still, we could even freeze some rare platelets, for example, some rare blood groups, platelets, and have them reactivated after a while, and they still work. They lose over time, and this is something to digest. If you store them for more than 7 days, then they will lose some of their function, but still they are activatable, so they are still useful.
Yeah, yeah, great. Dr. Marcus, as the in 2000, since more than 23 years, I read that the cross-matched fresh blood can be transfused to refresh or to compensate for the thrombocytopenia, as the fresh blood, fresh donated blood has not preserved at the temperature and preserved at room temperature, which may be more than 24 degrees centigrade. Is the of value till now to transfuse this cross-matched fresh blood for the patient to compensate for platelet deficiency or any part of coagulation defect?
This is something which comes actually back at the moment again, like the stored platelets, the cold stored platelets, the discussion about fresh blood. And there are, as you said, different, similar to FFPs, there are different types of fresh blood. You have the whole fresh blood, which is really warm fresh blood. Then you have the whole stored fresh blood, which could be stored under cooling situations, which is, I think, again, 4 to 8 degrees. And there is also some attempt for some rare blood groups to freeze that blood in order to have them available if you have a very rare blood group, for example, with rare antibodies. It mainly comes from the military massive transfusion scene, where people think that they do not have a proper blood bank available, and they want to have, as they call it, the walking blood bank, so they use their soldiers as the blood donors directly to the patients. In that setting, it might be beneficial. If I look at the situation in civilian areas, there are investigations in trauma patients, but also in PPH patients, as I know, where they look at the effects of whole blood, and in pediatrics. It seems to be effective, but we must take this with a bit of with a grain of salt, because if we consider, and I think I touched on this in the final part of the presentation, if we first think about how the blood products are produced.
Yes.
They separate the red cells, they separate the plasma after giving anticoagulant into this. So you have a dilution, then you separate it, and at the end, if you mix all the products together, you will never get the quality of whole blood. So I think this is the magic about the idea that whole blood might be better, because we never can reconstitute as it was before, because the amount of anticoagulants is higher there.
Yeah.
And by this, we have, if you mix it even 1-to-1 together, we have lesser platelets there, we have lesser HB there, we have lesser plasma concentration of coagulation factors in there. So that is the major part. I'm not a big fan of this idea to go back to whole blood, because this also gives a higher chance of infection. And if we see, and as we are in low and middle income countries, if we look at our donors and our blood bank situation, we know that our donors have a lot of risks, and
Yes.
the referral rate of blood donation is very high if we look at our areas, due to syphilis, HIV, hepatitis C, particularly in Egypt, this plays a major role, hepatitis C. So these are factors which we, of course, could test the donors for, but it may be still that we are not good enough to test all of them, so the chance of infection may be higher in the whole blood scene. So the last word is not spoken about this issue. I'm not a big fan of this. I'm a little bit skeptical, but let's see what comes in the future.
Yes, yes. Dr. Marks, I would like to ask, I'm so happy that we have factor 14. I'm so happy. This is time factor. So, as we mentioned in many times, is that time is brain, time is heart. So, you said mentioned that time is blood.
Yeah, it is like this. There was
Yes,
one interesting study a while ago when they
I'm happy.
evaluated.
I understand the good. Time is blood.
Yes, time is
Yeah.
blood. You're completely right. Because if you look at this, there was a study which was quite height, where they wanted to investigate the effect of fibrinogen concentrate on aortic root surgery, and this was a multi-center study, and this was actually after single-center studies showed to be positive if you give fibrinogen concentrate in terms of stopping the bleeding, that the multi-center study suddenly turned out to be not as positive, rather negative. And I was lucky to be invited into the advisory board to look at this. And it turned out that in an area where the people were very disciplined, which is Japan, the guys were actually waiting a long time in order to look at the bleeding and to calculate how much fibrinogen would be needed. And those results were actually equal to the fibrinogen concentrates, which means that if you take your time, if you give the clotting a time, then it maybe also overcomes some deficiencies. And we see this in daily practice. If I send my surgeons during the heart surgery out of the room, asking them to take a break, to take a cup of tea, and to let us deal with the bleeding, and we just give the time and maybe a bit of fibrinogen or a bit of cryo, whatever you have, the bleeding stops all of a sudden. So time is very important in bleeding. Yeah.
Yes, yes. So it is the early detection of coagulopathy and the early motivating the hemostasis and use your drugs, use your army to enhance hemostasis and prevent the coagulopathy.
Absolutely.
For example, as you mentioned, Dr. Marcus, that trauma, especially in case of shock and acidosis plus hypothermia, we will have more blood loss, more coagulopathy developed. So especially for trauma, especially frail patient, we may lose our patient or obliged to have massive transfusion, more coagulopathy, more stored blood, more coagulopathy, and we may lose our patient if we lose our time or the golden hour of blood transfusion and keeping hemostasis at proper time.
We could
Yes.
call it this, and I thank you very much for this comparison to sepsis. That we should maybe think about the golden hour of coagulation as well, as we know this from sepsis. You're right.
Yeah. Yes. Yes. Yes, it's really a great point you mentioned, and I learned it from you now that we have factor 14, and we should expand this point for all our colleagues. So we have now a question from Dr. Sharif Bouzaid. Welcome, Dr. Sharif. He asked about how polycythemia can affect coagulation in infant with congenital heart disease.
How what, please? How polycythemia?
Polycythemia.
Polycythemia.
Yeah.
Okay.
Polycythemia.
This is a very, very good, but also again a very difficult question, because it depends, of course, which cell line is increased. So which kind of polycythemia is there? And again, it depends on what disease we are looking at. Because if we had, if you see, for example, at hemoglobinopathies like a sickle cell disease, then we see also that the surface of the red cells are different than the healthy cells. So in that sense, they have some kind of procoagulant activity. So once it comes to a sickle cell crisis, for example, then it turns out that a coagulation will be activated, and it all runs over the platelet activation then again. Yeah. On the other hand, and this is something with a really polycythemia, it could be that there's abnormal function of the receptors, which could lead to a hypercoagulation and a clotting phenomenon. So we could have both. We could have a bleeding and we could have a clotting phenomena. And coming back to the other part of the question, it was inherited pediatric cardiac disease, if I understand. Then there plays across also that the question whether it is a cyanotic or non-cyanotic disease is a problem. Because if we see that there is a cyanotic heart problem, so the kids are blue, the blue babies, they have a more procoagulant derivation, so they are clotting easier than the ones which are not blue, so the not cyanotic kids. And this has partially an explanation in that increase in cells. Yes, there is a clear defect. And this is also shown in literature.
Yeah. So either the number or the quality of RBCs may affect the coagulation.
Right.
Okay, yes.
Right.
Dr. Sharif, fine, Dr. Sharif?
Does it answer? Yeah, I don't know if this answers your question.
Yeah. So any question again from the floor? So yes, Dr. Sharif, thank you, Dr. Marks. So to start the second part of our session today, the last comment from my side, during a crisis or during, for example, earthquakes, any disasters, how much unit of O negative blood I can transfuse for my patient in this disaster?
A very good question.
If I haven't the cross-matched blood for my patient in these disasters.
If you have a real disaster, then you have a real problem because you don't have enough of this O negative. But to come to the question about how much O negative you could transfuse, this brings us to the discussion about what happens, because in the O negative, we will have maybe antibodies against A and B. So then we transfuse into our patients, of course, antibodies against A and B, and depending on the level of blood loss, I think at some moment we will wash out all blood of the patient, and then we could simply continue and carry on with the O negative infusion, because we will simply dilute the blood of our patients so much that there is no really a limit to give this. Having said that, at some moment, once the patient is stabilized and he or she will again produce own blood, and then this issue may come back and you may have a delayed problem, a delayed transfusion reaction, which is transfusion reaction 3, if I'm not wrong. But at the acute moment, you can give O negative as much as needed. Meanwhile, the recommendations of the AABB, the American Association of Blood Bankers, goes even to the fact that they say you could even give O positive blood if the antibody titer is quite low.
Yeah.
So this is also allowed meanwhile, and this is important in regions, for example, here with us in Kenya, we have very little O negative donors. And if we have a problem there, we could use O positive packet cells with a low titer of antibodies. So this is also allowed meanwhile, but this is still a decretion of the blood bank.
Yeah, yeah. Thank you, Dr. Marcus. Yes, we can start the second session.
Okay, so
We are so pleased and honored to have you today. Thank you for your endless effort and support. Thank you.
Thank you to stay awake and to stay with us, because I know it is a long evening. Let me just transit to the 0, and then we come to the next one, which is bleeding diagnosis. We talked a bit about coagulopathy, and now I want to carry us a bit about diagnosis and into the diagnosis part. And first of all, I want to talk a bit about the so-called standard laboratory tests we all are very known with, and we know from medical school, of course. Our laboratory could deliver us some, my former mentor, Dr. Hanskins, called this the so-called screening laboratory, and then the confirming laboratory tests. As the screening laboratory, which happens in the whole blood, you know very well, the whole blood count, the CBC, which delivers us the HB or the hematocrit, the thrombocyte count, but also the mean platelet volume. We could also think about the viscoelastic tests, which are done in whole blood, and the PFA or the multiplate as more or less specific platelet function tests. We come to this during the ride. The classically coagulation tests, as we know them, are plasma tests, which directly brings us to the later coming back point that we need to separate the whole blood from, or the blood through particles from the plasma in order to execute those tests, which is the PT, the APT, a mixing study, as I already mentioned, then the trombin time, but also the anti-10A levels, which may be important if we think about drug-induced coagulopathy, for example, the DOACs. As confirming laboratory, and they take a little bit more of time, fibrinogen levels, antithrombin, but also then several factor analysis may be important if we investigate our patients more into the depth. The problem is, and this is already again old knowledge, that the traditional plasma tests, as we know from our laboratory, have actually a very low level to predict bleeding, but also to support us in our diagnosis and treatment. For example, we know that the APT has a bit of a misinterpretation due to some kind of physiological variability. I already introduced you into the fact that a prolonged APT could point to a factor 12 deficiency, which is not going together with a bleeding tendency. But also we know that the lupus anticoagulant, as we know, some of the reagents, not all, some of the reagents will show us a prolonged APTT. So in that sense, it may be prolonged without a real bleeding tendency, the APTT. Similarly, the trombin time, the PT, maybe also give us different results, and also depending on the reagents the laboratory uses, and by this the different sensitivities to different factors may be important to evaluate. Therefore, actually, the PT was further developed to the so-called INR, which I come to in a couple of minutes to give you my criticism on that part. Again, in the fibrinogen measurement, which is something people like to know, of course, as fibrin plays a major role in bleeding, the fibrinogen measurement has different ways to measure, either by photometric or by mechanical or by true barometric measures. And if we come to the limits of the fibrinogen levels, which is still seen as the 1 gram per liter, below there, these methods actually overestimate the amount of fibrinogen which is in the sample. In other words, we think there's much more in than in fact is. And if we mix some Hess into this, we even are overestimating this much more. So in other words, the Hess has not only the effect on the coagulation itself, but also on the measurements. And I want to show you a very old study from 1998, where they did some experiments on the measurements of APT and PT. They used different reagents. Some were very sensitive and some were less sensitive. And then, as you see here, in the most sensitive, out of 16 samples, 15 showed prolonged APT and PT, while out of the least sensitive, only 2 showed a prolonged APT on PT, more than 1.5 times prolongation, which means actually that the first row would be exposed to a treatment, while with the least sensitive reagents, the patients would bleed, but they would not even be treated. And this is something we should keep in our mind, that our laboratory, although we all believe that this is the truth, does not really tell us always the truth. And I will try to explain this a bit more. And we know, and this is only an example here, sorry, it's a bit, yeah. We see that, and this is the Gonzalez study from 27 already, that depending, the INR is directly correlated to the probability to die on the ICU after trauma. So if we consider these measurements, then I take into doubt this result, because I would ask what kind of reagent did the investigators use, and is it really a matter of fact that the INR was prolonged here, or is it only an artifact which we see due to different reagents? And we know there's a nice study published in the BJA already a couple of years ago from our friends Haas Fries and also from Lars Asmus and Schechel, where they said that the standard laboratory tests are actually only exploring and giving us results on ex vivo situations in plasma, which is mostly citrated also. And they are far from the in vivo situation, which means there are no particles in, there are no red cells and there are no blood cells in, which, as I showed you already earlier, contribute to coagulation. Interestingly also is that the standard coagulation tests are mostly measuring to the point until the clot starts to formate. Then they stop. It is only a measure of time. They don't measure the thrombin burst, as the thrombin burst mostly actually takes place after the clot formation started, as I told you, in the cell-based model. So the standard laboratory tests are actually more developed to give us ideas about factor deficiencies, and also they are actually developed during the investigation of the coagulation system, the waterfall cascade, where the investigator described which factor is leaking, which factor is better or more inhibited, and at some point, the APT is actually a measure for the heparin effect, while the PT/DNR is more used for the vitamin K depending factors to measure as a drug monitoring effect, if you want it like this. Problem is here that our standard coagulation tests mostly are not capable to predict or to guide us into a bleeding patient. For that reason, but also for that reason, that they are much too slow. And I know that we have all the same experience if we send a sample to our laboratories. The turnaround time is quite long until we receive this displayed either in our computers or even by phone, that the laboratory guy calls us and says, oh, there's a PTT prolonged. It takes long. So how can we guide then a good therapy if the test is not very well designed and the time is long? And we did some study already back in the Netherlands, and I'm very happy about Dr. Henskens again, who shared that data with me. And let me show you here this. We had put together the platelet count measurement only, it's a CBC, and the fibrinogen level. If we requested this in a university hospital, tertiary center, on urgent base, it took 26 minutes median to get an answer, but it took roughly 1 hour to get an answer on the fibrinogen level. If we push it much, much, much more, then we get the platelet count in 13 minutes, which is good. Fibrinogen level still in up to 40 minutes. If we compare this to the whole process to set up a viscoelastic test, and here this was one where we needed still to be PET, not one of the modern ones, then it would take us 12 minutes to have some kind of an idea what happens until the A5. I come to this to explain what it is, but just look at the timings. There was one interesting study, if I can get it on the screen, yes, where Chandler and coworkers tried to have some kind of exaggerated, speeded their testing, where they wanted the turnaround time to be below 20 minutes. They called it the emergency hemorrhage panel, which gave us a PT, a fibrinogen level, a platelet count, and a hematocrit. And this was the way how they tried to speed it up. They skipped a couple of processes. They speeded up the centrifuge, particularly up to only 2 minutes, and they analyzed this all, and they managed to get this done in 14 minutes, which is already extremely fast for a laboratory. And I swear you, that no laboratory in the world, unless they really try to do this, will deliver this to you. So in other words, those tests are a little bit too slow. Still, let me come a bit to the plasma test. And this brings us back to the classical cascade, as we know, as I described earlier, intrinsic and extrinsic pathway, while the intrinsic pathway is described by the APTT, extrinsic pathway is described by the PT/the quick test, and the common pathway is a trombin time or depending on a fibrinogen level. I only go quickly to it because I think it's not our topic and it's a bit too much. Trombin time or INR is actually the extrinsic pathway. They mix some stuff to it, which is mainly tissue factor, calcium to counteract the citrate, some platelets maybe, and some buffer. And then they run it to a test. They give in addition, and this is the reason why this test is not sensitive to heparin, they give some heparin neutralizer in there, which may be polybrine or other, but mostly it is polybrine, to neutralize heparin up to 2 units per milliliter. So if you are considered to be in cardiac surgery, then you still have an abnormal INR due to heparin effects while you're on the pump, because there the concentrations are sometimes higher. But essentially, heparin is neutralized there. Then it measures mostly the vitamin K depending factors, as we all know, and it will be then compared to normal plasma. This gives us the INR. It is low, of course, in different situations, as you know. If, for example, our patients are on a therapy, if we have liver disease, if the patient has, for example, an inhibitor, if there are some deficiencies, or if there are extremely high heparin doses, as I just mentioned, or, and this is something we highly, highly underestimate, if we or our nurses simply do a pre-analytical error, which means that we have our citrate tube not properly filled. Because the citrate tube contains citrate, which means there is liquid in, as you know. And if the ratio between the mixing liquid and the blood we put in is not correct, so if we don't fill it up to the level which is meant to be filled, we have a mismatch. And then the calcium we add in, or the test guys add in, as depicted here, is not enough to counteract the citrate, and then we have an artificial prolongation of the factors. This is true for all coagulation tests, by the way. So then coming to the prothrombin time a bit, let me go through. The INR is then nothing else than a comparison to a standardized test. So this is the same test route. Then they use a standardized sample, and they multiply this by ISA, and then you have different standardization methods, so you could get different INRs. And this is one dangerous thing, and let me show you this. Again, quite an old study, but it's still true. I looked it up. This is a Finnish study. These are different INRs measured in different centers from different patients. So each line is a different patient or different sample, and each 1 to 3 on the x-axis is a different center. And here you see that there is a huge variability between the centers to measure the INR, which means if you are in Cairo and your INR is probably 5.8, and you come to me, maybe to Nairobi, then it might be that your INR is 3. Now you can ask, does it have a therapeutic consequence? I would say yes. Maybe not in a theater, but if you consider whether or not to give a vitamin K antagonist, or whether or not to think about a bleeding issue in that patient, you may be, of course, very concerned with an INR of 5.8, but you will be, to a lesser degree, concerned with an INR of 3. So in other words, the INR is also not whole of the truth. Sorry for that. Let us go on. The APTT. And now we are walking the intrinsic pathway. Again, coagulation needs an activator, as always. So after spinning off the blood from the red cells or cells from the plasma, we add activators, which is the intrinsic factor activators, so contact activation, electric acid, silicone sometimes, kaolin sometimes. Then we need phospholipids and again calcium to antagonize the citrate. we need to incubate this a bit to activate the contact system, and then we can measure, again, the time until clot formation. It measures more or less, as I said, the intrinsic pathway, so factor 12, factor 11, and so forth, and so forth. Again, it is prolonged if we have an error in our blood drawing, but also in those situations. And I don't want to go into much detail. Interestingly, as I showed you earlier, it is again depending on the reagent we use, how sensitive our test is. And this is again something from our former institution, academic hospital in Maastricht, where we see the sensitivity of towards factor 8 and diverse reagents. And we see here, this is on the x-axis of factor 8 concentration in that sample. And here we see the APTT. And we see that depending on which kind of reagent we use, we have different results. Now you could ask, is it important? I would say yes, particularly if you cross that yellow line, which is, of course, the upper limit of our normal value. And you could see that it makes a huge difference if you have either 40% of factor 8 in your body, and the signal is like here, still normal, or we have 100% and it's just the same result. So it makes a big difference, because if we look then at the phenotype of our patients, they may bleed with 40% of factor 8 in their plasma. But if we consider we have a more sensitive reagent, then we may come to a normal result with 100%, and the patient has obviously no bleeding tendency. So there is a huge problem with our laboratories. And again, this is what we see, how we can measure. A prolonged APTT is seen in these situations. It may be normal in situations where we don't expect it. Some other factor 7 deficiencies, some light vitamin K deficiencies, and both may be prolonged in those situations. And what is missing here, oh no, it's here, if there is some NOAC activation here. Going to thrombin time and Klaus, because I don't want to extend this session here too much, as it's very much laboratory-minded. The thrombin time and the Klaus are at the final part of the common pathway of the coagulation, as you see. It actually uses a little bit more of thrombin already in our dilutional part, in our activation part. It wants to measure fibrinogen, but it will also add some fibrinogen in there. And there is mostly no additional calcium in there, as there is some overactivation of the coagulation already. And the thrombin pump is prolonged in heparin, of course, in pyridine, but also if there are split products and if there are some rare antibodies in there. Not interesting for the anesthetist, by the way. Interestingly, and this is an interesting experiment from an anesthetist, as you know, Dr. Solomon is an anesthetist. She, meanwhile, moved since a long time to industry, but she is an anesthetist from her training, and she did some investigations in the different fibrinogen measurements. And as you see already in that error, there is an error in the error, which means there are different kinds of measurements. Some are photo-optical, some are electromechanical, some are really mechanical, like the steel ball, and some are antigen dependent. And depending on, this was in cardiac surgery, which method you use, you receive totally different results for your fibrinogen level. So with this photo-optical measurement, you have a borderline, and then depending on your test you use, if you use a T-ball, which is much more sensitive seemingly, it gives you higher results pre but also after proton. So in other words, again, the decision whether or not to treat could depend on the method, how you measure this. And this should, with all due respect, not be the case. So again, there is some under and overestimation here, as I told you already. Similarly, the anti-10A measurement we use mostly to measure the effects of the direct factor 10 inhibitors, the NOACs, but also to estimate the low molecular weight heparins. In the ICUs, for example, is the chromogenic test mostly. The important thing here, and I want to point this out, those tests need the calibration for that specific drug. which means if your laboratory gives you an anti-10 measurement for your therapy on the ICU, which may be enoxaparin or whatever, then it will be standardized for that. You should not use the exact same test to evaluate an effect of rivaroxaban, because this may mislead you. This should be calibrated for the rivaroxaban, and then you could use it. But this must be known by the laboratory. And as you see here, if you look at LMWH, it should be also measured at a good time window, because it makes a huge difference if you apply this subcutaneously when it had been given and how it has been resorbed. So it should be either used at the peak, 2 hours, also at a low level, 2 hours before the measurement, or 4 to 6 hours after injection, or both, to evaluate the good effect, which means whether you are in the prophylactic, which is between 0.2 and 0.3, or in the therapeutic range, which is 0.5 to 1.0 units per milliliter. For LMWH and for unfractionated heparin, it's a little bit lesser. But anyhow, this is something we should keep in mind. And this is enough, I think, for the laboratory tests. And for those who are interested, we could discuss maybe a little bit more later on in the discussion. I now want to come a little bit to the viscoelastic tests, because they are very hip and very much under discussion. And they're also part of my own interest. Actually, this is one of the early thromboelastograms, TEG devices. This was developed in the mid of the last century by a German guy, and it was then discouraged due to several reasons. One reason was it was at that time very work intensive, very time intensive, because this part here is the measuring area which had to be cleaned. And on the other sense, the people who were evaluating coagulation, mostly the laboratory doctors, but also the medical doctors, were thinking that this is much too insensitive to give them an idea about a certain factor deficiency, and therefore it was left behind. Having said that, meanwhile, we are a little bit more sophisticated. This is how the drawings, the results may have looked like at that moment. Meanwhile, the tests are a little bit more sophisticated. We have two major differences here. One is the TEG, and the other is the ROTEM. The major differences here are the moving parts. At the TEG, which is the left side here, we have the pin, which is put into a cup with the blood, where the activator is in, and then this pin is hung up on a wire, and the movement of that wire is measured. So the cup is turning, and once there are fibrin strands formed, this pin receives a little bit more of resistance. So this wire is a little bit more moving, and this is the reason why you see such a curve. From the beginning, no activation, and then there will be activation. Similarly, but different, is the ROTEM, where again we have a cup, again we have an activator, but here there is a pin in, but here the pin is moving. The pin is at the upper part of this in the machine, having, let's say, something like a mirror, where the light beam is coming on. This will be reflected to a detector, and then the movement of that light beam will be translated into a curve. So the measurements are slightly different. The activators are slightly different, and the movement of either the pin or the cup are with different angles. For this reason, we cannot simply transfer results from the one method to the other. So if, for example, an R time in your TEG is prolonged by XY, it does not mean that the CT time is equally prolonged, because the measurements are simply a little bit different. And if you look at other measurement devices, like the Quantra, I come to this, it's the same. Coming to that figure, the figure is always a little bit similar, which means we have in the beginning, we have on the x-axis, we have a time. On the y-axis, we have a millimeter, which reflects the stability of the clot, which is reflected in the movement of that wire or that mirror, as I told you before. We see that we have different areas, you may know probably, and this is now the ROTEM. Please excuse me, this is not the TEG, but the principle is the same, but the results are different, as I said. So we have a starting point where no clotting is actually happening. Then we have the propagation and amplification period. So first is the CT, the clotting time, which is measured in seconds. Then we have the clot formation time, which is the amplification phase, which is measured again in seconds. And this is actually per definition. Once that measurement here goes over the 20 millimeters, CFT stops per definition. And then the machine only gives us stability indexes, which means millimeters, like the A5, so stability of the clot at minute 5, stability of the clot at minute 10, and so forth. This is A5, A10, A20, whatever you like, until we come to the so-called maximum clot formation, so when there is no more stability reachable. And then we go after 50 minutes to 60 minutes into a lysis, which is to some part natural. Just to remind you, our laboratory clotting tests stop here at the beginning. So actually, they do not tell us how stable the clot will become, and they do not tell us anything about a lysis. I told you already there are different makes. We have the TEG, for those guys who like the American way, or the TEG device, which is the prototype is this, the old style device. And we have the TEM, or the ROTEM, as it's called nowadays, which is that prototype. There are different activators or inhibitors of the coagulation, depending on which route you are going to. And we could maybe discuss this in a discussion, because I don't want to go into much detail. Depending on which kind of activators or inhibitors you add to the cup, you could see either the extrinsic pathway or the intrinsic pathway, or you could see what would happen if there would be no heparin in. This is the heparinase way. Or you could see what happens if there is the fibrinolysis inhibited. This is the aprotinin way. Or you could see what happens if the platelets are not there, which is then giving us an idea about the fibrin content or fibrinogen content, which is here either cytochalasin, or here it is another inhibitor of the platelet function. Why shall we go to viscoelastic tests? I said it already, but I want to repeat it again. There are certain advantages, like we can see the fibrinolysis quickly, which is in other tests not visible. It is in whole blood tests, which is actually taking into account the cell particles, which are playing a role into coagulation. It is quite quick, and if it is embedded into good algorithms, it has advantages in terms of treatment. But there are also disadvantages, and we must keep this in mind. The classical old stylish, and I go back to that once here, devices, they needed still us to pipette. And as we are not trained as analysts and lab technicians, we may have made some mistakes in pipetting. So this gives a huge of variances. And this was one major point of criticism. And this gives sometimes also low quality in the test. In general, the viscoelastic tests have not a high predictive value for bleeding. And if we apply them even in a correct algorithm, we do not know yet whether this has a benefit in mortality. And as mortality is a very hard endpoint, the literature still needs us to give a good result in that. But again, it is faster, it includes cells, and it doesn't stop once the correlation tests, the classical ones, are stopping. And this is the only test which shows us, although after 50 to 60 minutes, the effect of fibrinolysis. It could ease our therapy at the bedside or in the operation theater. It could give us an idea about how to individualize coagulation treatment, and it could avoid over or under treatment. Does it make it better? As I said, prediction is not very high. So if we draw a ROTEM or a TEG or whatever you like, a test preoperatively, it will not tell us whether that patient will bleed because there are too many other players in the field. But if we do this, for example, in the emergency room, and we look in the emergency room about bleeding chance, then it has a benefit effect because then we could start earlier treatment. And treatment maybe is already shown. Treatment is improved in cardiac surgery, in trauma, in liver transplant, but also in other major surgeries. So at the end of the day, if we embed this system into a good algorithm, it could help us. And here, another player on the field, I don't want to leave this behind. It's the ClotPro, another device which looks similar to the ROTEM. And don't be surprised, the developer of that device is the same like the ROTEM. It has a little bit of differences, a little bit of advantages. I only want to mention this here. The pipettes, because it still needs pipetting, are already containing our activators of coagulation or inhibitors. So there are different styles of pipettes, and therefore it reduces the chance of error that we mix something wrongly, but still have good results. And there are different assays we could use. And another advantage of that device is that it gives us also an idea about the ICA test, where we get an idea about the dabigatran, so the direct thrombin inhibitors. And it gives us an idea because it has some Russell Viper venom tests, like where we could have some kind of an idea about the direct factor 10 inhibitors, so the rivaroxabans. So therefore, I mentioned that test. Meanwhile, we have also the fully automated tests, as you may know. There is the ROTEM Delta and the TEG6S. They are easier in handling, particularly for the novices, because we do not need to pipette anymore. They apply cartridges. This is one cartridge of the ROTEM, and these small balls here indicate you the different tests which are applied. So these are the reagents. And as you see here, 1, 2, 3, 4, 5, this is the control. 4 tests are always run in parallel. Similarly, the TEG, there are also cartridges, and they are also put in here. Here are the different activators in. And once these are put into the slot here or there, they run the tests without us doing any more pipetting. Important thing to mention about the TEG6S, because people think TEG6S is the same like the classical TEG. It is not, because it applies a different technique. Although the literature says that the results are comparable, it does not mean that it is one-to-one the same. Because on the left-hand side, as I told you, on the classical TEG, the cup is turning, the torsion wire is moving at some moment after the clot has built up. So that is the measure. And with the new TEG6S, there is a capillary which is filled with blood. There is some sonography, some ultrasound applied to that. So there will be some distortion of that blood column. And this is actually here below measured with a camera. And this measurement, of course, once the clot is getting more stable, is changing. And by this, the coagulation will be assessed. So the method is totally different from the classical method, just as a reminder. Coming to that, it was always a bit of difficult to evaluate the test. And meanwhile, there were some interesting and some smart guys saying, okay, if you never had seen such a result, if you never had seen all these numbers, which may be very confusing to the novice, they give you some kind of a help, which is the visual clot, which is nothing else than that device takes the numbers, which is derived out of the measurements, and then it translates this into some kind of visual information to tell you, oh, there may be a little bit less of platelets, or there may be a little bit less of fibrinogen, or all of this is limited. So then it gives you some kind of an idea what the problem is. So this may be a problem that there is too much heparin maybe in there, and this may be a problem that there is too little of fibrinogen, as you see here. So this is some kind of if you want an interpretation support. Still, as everything in life, viscoelastic tests have limitations. They do not reflect on von Willebrand factor. They do not, in contrast to some statements, give us any idea of platelet function. They give us an idea about platelet contribution, which is mainly platelet count, but not function. And they give us a little or poor information about factor 13. And of course, endothelium is not assessed in any coagulation test. Another new development, only to mention this quickly, is the quantra, which is not giving us the classical curve as you see here, but numbers. They could be translated in a curve. They have also a curve display. It applies a different kind of technique. Again, ultrasound is used. The blood is getting into swings, and the changes of swings over time after clotting has been activated will be measured a little bit different than with the TEC6S, but essentially they create some kind of shear modulus, which is translated. I don't want to go into details. The beauty about the system is, again, it uses cartridges which have different activators and inhibitors. So you could do similar like with the classical TEG or the ROTEM. So this is some kind of improvement if you want it like this. But you have to be used to the system. You have to be used a little bit to the numbers again to interpret this nicely. Coming to the final part of this part of the presentation, where we go a bit about platelet function, which is my major interest. This tiny guy was already shown, which is a platelet with all the receptors. And there are a couple of platelet tests which may be interesting also for the anesthetist, which is the classical light transmission aggregometry, the impedance aggregometry, the clonal platelet analyzer, the Verify Now, and the platelet function analyzer 100 or 200, which is the modern part of it. To give you a word about the light transmission aggregometry, actually, this is a very simple method, but a very work-intensive method. And therefore, it is the gold standard, but it is not applied frequently because it is using so much time. So if we see here this display, we need first to spin off our blood. So red cells need to be out. Then we need to standardize this for the platelet count. Mostly it is standardized for 200,000 platelets. Then there will be an activator of platelets given to that solution. And then a light beam will be sent through that cuvette in order to measure the light extinction. If you can imagine, once a platelet getting activated and they get sticky, they clot together, they may fall down, and then the solution clears. And of course, this is the measure we see here in that curve, the extinction curve, and this is directly related with platelet activation. And remember, this is the gold standard, work intensive, and standardized for 200,000 platelets. Depending on which kind of activator you give here, you can see look about aspirin effect if you give arachidonic acid. You could look at clopidogrel effect if you give ADP, or you could look at the collagen effect or any other effect you want to see. And it always needs to have a comparator sample, which means simple plasma without platelets as a comparator. The little bit more modern part of it, which is also applied at bedside, is the MAIA, the multiple electrode impedance aggregometry, which is quite simple. It sounds difficult, but it's quite simple. It uses a cup again, with two pairs of wires, and between one of such a pair of wire, there is an electrical current running. And in that cup, there is at the bottom a stirrer, and then there will be blood added because we want to analyze blood. So there will be whole blood added in. Then there will be some activator added in because without activation, no coagulation or slow coagulation. So depending again on the kind of activator, we could have an idea about aspirin, clopidogrel, or any other effect. Then, once this activator is in, the platelets at some moment get sticky. They have their fingers, they get sticky, they come sticking to the electrodes, and the impedance increases. And this is actually what is measured in that curve. Increase of impedance over time. And we see two curves here because, as I said, we have two pairs of electrodes. Actually, this is only the comparator, so that we have in one sample also some kind of a quality comparator. And the stirrer below, which I mentioned, is only enabling the mixing. Downside of this, there are some limits, particularly the platelet count is an issue, but also if there is an overwhelming amount of heparin in or protamine, this may also affect the results. So this is something we have to take into consideration, that the platelet count, like, let me see here, plays a major role, but also, as I said before, the availability of heparin in of overwhelming part or protamine may play a role. Again, this is the effect of platelet counts on the different stimulation. This is ADP, this is clopidogrel, this is arachidonic acid, this is aspirin, this is collagen, and this is TRAP. TRAP is actually the thrombin-like stimulation, which is the strongest stimulator. And you see there is a clear dependency of the results according to the platelet count. So, in other words, the manufacturer of these systems say that below 100,000 platelets, you should not, or you should be careful in interpreting those results. The PFA 100 or 200 is this device. It measures the time and time of closure, which means, again, we have a cup, there comes the blood in, and then we have some kind of a pressurizing here, which pushes down that capillary into the blood with the counteractivation of our citrate. And then into that capillary, the blood will be pushed in. It will get into contact with an activator, which may be collagen or epinephrine, which may be ADP or any other thing. And then, depending on the platelet activation due to the activator, there will be a stop of flow to the upper part of this area, which is the closure time. And this correlates with platelet activation. The problem with that system is it is, although seems very handsome, it is not very well standardized for other than drug effects or from Willebrand. All the rest is not very much sensitive. So if you want to assess platelet dysfunction due to cardiac dysfunction or cardiac surgery, you will not see this here very much. To cut it a bit short, the Verify now is a simplified measurement of the light transmission aggregometry, which is used by our friends in cardiology. And the coronary platelet analyzer is actually not very much used. It smears out the blood, and then it looks at the platelet aggregation on that level. Most of these are actually not very sensitive. The LTA is much too time intensive. It is more used for a general diagnosis. It's not very much predictive, but it could give you some ideas about drug effects. Impedance aggregometry is predictive and could give you some information about drugs. The cone is not very much studied into clinical practice, only in laboratories. The Verify now is predominantly done in cardiology, but mainly gives you an idea about the drug effect. And the PFA is only giving you a little bit of idea about the drug effect, but mainly it is very useful in thromboembolic disease. A short word about heparin-induced thrombocytopenia. However, this is again a crossroad. It appears to be relatively rare, 0.3 to 0.5% of thrombocytopenias in the ICUs. It has a prothrombotic effect, but also a bleeding effect. It is mainly depending on antibodies on platelet factor 4. which are detected by IgE ELISA. And first, as you know, there is first, if we think the patient may have this phenomenon, we should do the scorecard, the 4T test, if the thrombocytopenia is relevant about the onset, if there's a thrombosis or any other cause, and then depending on the results there, we could distinguish to go further with the diagnosis. The diagnosis, and this is the scoring test again, it evaluates the thrombocytopenia, how severe it is, then the timing, how rapid it came, and if there is any clinical phenomenon C, and if there is any other reason for thrombocytopenia to be explained. And this result then correlates the probability of the HIT to be there. And if it is there, we could then go for some tests, which may be the serotonin release test, which is actually the standard test to prove that this phenomenon is there. I don't want to go into detail because this is then again for the laboratory. And important is then that we stop the exposure of the patient. While we know that low molecular weight heparin has lesser risk, particularly the unfractionated heparin has a high risk, and we should stop, as I said, exposure. We should move to some alternatives, which could be an IV direct thrombin inhibitor or a phenylpyrinox, which is also available subcutaneously. Don't give warfarin because this could, at least in the beginning, increase the clotting tendency. And please don't give platelets then. And this is actually the end of the diagnostic part. So I would give you a chance to breathe, give you a chance to take a cup of tea maybe, to consider some questions, and or to ask some questions before we move on.
Yes, the second part more marvelous and huge and voluminous information. What a kind of scientist you are, Dr. Marks. You thoroughly investigate every point and clear it for us. So elegant lecture and so hard work you do the few days ago. I'm
No
so
problem.
sorry.
I'm
so
happy.
sorry for your effort. Thank you. Thank you. Everyone from the floor have any question? Dr. Marcus spent more than 2 hours and 20 minutes clarifying every point in hemostasis and the coagulation. You will not need extra effort to know anything about hemostasis and the coagulation. This lecture will be on our YouTube and YouTube channel, and every time you revise it, you more have information and you get satisfied but by this huge and voluminous information, especially about the investigation about the platelet number and platelet function and the thromboelastogram. I have only one comment. I know I am so tired. You are so tired, Dr. Marcus, but excuse me. And I have discussed it with you since 1 month ago about the usage of thromboelastogram in diagnosis and management of postpartum hemorrhage.
Yes.
And we haven't it in our hospital, in major of our hospital.
It will come into in the final part, but let me go a little bit ahead already. It has meanwhile a very good position into the therapeutic algorithms and into the diagnosis. Because of the reasons I told, it is quick. It could give us maybe better ideas about what is missing and where we could start treatment. And there are meanwhile a couple of good studies out showing that if you apply a thromboelastogram in PPH, at least after a certain loss of volume, and PPH is about 1.5 liter of blood loss, then it has benefits. I think already in mid 2010s, 2015, from the UK, there came a nice study from Shubha Malaya, where she showed this is effective in terms of reducing the exposure of the ladies to unnecessary blood transfusion, and at the same time coming earlier to a stop of bleeding. Because particularly what happens in what I saw also in Qatar, that there is a lot of course, panic arising once a lady is bleeding during delivery, and the panic then comes frequently from the other side of the curtain, which are the obstetric doctors, who are saying, "Oh, give this, give that, do this, do that," and this is very much confusing and very much unnecessary if you try to guide this. So it could give you a good idea. And I will show you our algorithm we developed for Qatar for the PPH in the final part of the presentation. So yes, it is proven in PPH, it is proven in trauma, it is proven in orthopedic surgery, and in particularly in cardiovascular surgery, that in all of these 4 situations, the implementation of viscoelastic tests has a benefit for treatment. It is not yet clear if it is a benefit in mortality, as I said, but the assumption arises that it may be benefit, but it's not proven yet.
Yes.
Maybe
Just
if we go to the therapeutic part, we could work on this more, but please carry on.
Yeah, just only I depend upon on the clinical situation and the hemodynamics of the patient and the amount in the canister of the suction apparatus and the towels, etc. And I have no thromboelastogram in my hospital, even in the university hospital, we haven't one.
Yeah.
Thanks, Patrick. Patrick Ulang from Kenya. You know him, Dr. Marcus. Thank you for you, Dr. Marcus, for your great lecture. Anyone from the floor has a question?
I need a cup of tea.
Yeah.
I think they all need a cup of tea. They're all tired.
Yeah. Anyone have a question? So, Dr. Marcus, sometimes the internal milieu or the internal environment of our body, when compensating, and when be in best environment as regard the body temperature, no antibodies, no chronic disease, no comorbidity, may help to have sound and the proper coagulation in spite of influential factors that may spoil this function?
Yes, certainly. And this is interesting, as you said. This is one part of the explanation why in hemophilia, the bleeding tendency in hemophilia is not always one-to-one correlated to the level of coagulation factors, which is missing, which is factor 8 or factor 9. So you cannot only by knowing the level of the coagulation factor say that patient has a bleeding tendency. And this is the most common known situation, but if you bring it back to the traditional patients we have, and we are just about to publish a study which I did with a friend in Brazil, the thrombocytopenia can partially be compensated by higher amounts of fibrinogen.
Yes.
So if the patient, for example, we did a study this on hematological patients with thrombocytopenia who had a sepsis or not. And there we see that if the patient had a sepsis, due to the sepsis, interestingly, they had higher fibrinogen level, and this fibrinogen level could compensate for the thrombocytopenia defect, or effect on the coagulation. And we did also in earlier studies some mixing studies where we gave fibrinogen concentrate to blood which had lower platelets. And there it shows also that you can compensate a missing factor. So this is something we also apply in clinical practice. So in clinical practice, I don't use platelet concentrates before I'm really sure I need them. So I first give correlation, FFP, cryo, or whatever, and then later on I would give platelets at some later stage. So this also translates into clinical practice. Yes.
Yes. You mentioned Dr. Marcus about the thrombocytopenia. So in this point, I would to concentrate to what extent we can depend upon the clinical situation. If our patient have no petechiae, have no proficial bleeding, have no ecchymosis, is bruising, or no history of bleeding at all. At what extent we can depend on this clinical picture and to proceed for intrathecal anesthesia during labor in this type of patient.
That's a very good question, which has been asked.
What is my lower limit? Please,
I
Dr.
know,
Marks.
I know. I know you would now like to hear me saying you could do a spinal with
I wanted
20,000
to have a
platelets.
certificate from you, sir. I want to have a certificate
Yeah.
from you.
No, it is. See, we know that the platelets we can do a safe puncture until platelet counts of down to 80,000. Some people who are very secure in their technique go even down to 50,000. But there the problems occur that we do not know for sure, because there we come to the limits also in terms of the most diagnostic procedures. I didn't mention this, that most of the diagnostic procedures again rely on the platelet count. So if the platelet count is low, the result is very difficult. Clinically, I would not recommend to go lower than 50,000 because we know from studies which are looking at spontaneous bleeding in hematological patients with thrombocytopenia that the variance is huge. There are patients who do not have a spontaneous bleeding when the platelet count is even below 5,000, but there are already patients which bleed or who bleed when the platelet count crosses the 20,000. So in a hematological patient, the border might be somewhere between 15 and 25,000 platelets for spontaneous bleeding. But as we are challenging the system by doing a needle in the back, I would not go below 50,000 still. I would say, okay, we want to be safe for the patients, and I would not go lower than that.
Yeah. Yes. Yes, it is tailored one. We may have near future, as you know, sir, as regard precision medicine, some people will have just a phenotype or just a genotype to predict that they may have coagulation defect or hemostasis defect in some certain ethnicity or certain races or certain countries or certain phenotype of people. Those people will have coagulation defect or homeostatic defect.
Yes, yes, this is right. I mean, there is already a huge knowledge on the genetic effect on particularly on platelet disease, mostly inherited platelet diseases, which are frequently not visible as long as the system of coagulation is not challenged. So as long as there's no operation, the patient will never tell you he or she may have a bleeding tendency, but due to the fact that we can identify the genes at the moment already, or a lot of the genes, not all maybe, there may be a moment coming that you just take a sample and push it to some PCR device, and then due to working off this with some AI supported whatever algorithm, it says to you, this patient may have a bleeding tendency. Yes, you're right. And this is the future, I think.
Yeah, so I read a few months ago that in Africa and in areas around Vietnam, the female patient there may have some thrombocytopenia in this type of environment in middle and east of Africa and the area around Vietnam.
Mm-hmm. That's very true. It's also partially depending on the situational aspect. As you know, in some areas in Africa, they eat a lot of hot food. I mean, not hot in terms of temperature, but spicy. And likewise in Southeast Asia, they eat a lot of spicy food. And
Yeah.
recently, a colleague of mine told me that these spices, these chili-like spices, they have
Yes.
clear effect on the platelet function as well. So there may be also interference here. So it's not only the inheritance, so the genetic factor, it's also then the environmental factor which plays a role. Yeah.
Yes. We have a comment from Dr. Muhammad Manna about the platelet number in pregnant patients. Even if the patient is on aspirin, continue.
Uh, Good question, Dr. Mohammed. No, I would not go to 50,000. I mean, if you are very confident in your spinal, you may do this, but I would not recommend this. No, if you have a patient who is on aspirin, I would stick to the 80,000. And if there is any other anticoagulant in the game, I would not even recommend this, and this is according to the guidelines already. If there are two anticoagulants, either an antiplatelet or heparin-like anticoagulant as a combination, you should not do this. You should at least have, with aspirin only, you could do until 80,000, but below 80,000, I would not recommend.
Yes, yes. Yeah, about you mentioned, Dr. Marcus, that the thromboelastogram is not part of our routine in pre-operative. Yes.
Yes. When I came first into touch, many people it was in the early 2000s, many people were doing the TEG or the ROTEM, whatever they had, also in the pre-operative phase in order to have an idea about the bleeding tendency. And then a couple of people tried to look scientifically on that aspect. And it turned out that the predictive value is not very high.
Yes.
Of course, this is easy to understand as you see the situation. If we have a cardiac surgery patient or a PPH situation, then the bleeding is not exaggerated or enhanced by the status at the beginning.
Yes.
But due to the fact that there will be coagulation factors consumed and there will be blood loss and dilution, so therefore it is easy to explain why this predictive value is quite low. If you look at the trauma setting, of course, once the patient arrives into your emergency room, so many things happened already, and there it is known that particularly the lysis and the severity index, the ISS, the injury severity index, is very much predictive for the severity of the bleeding and for the chance of massive transfusion. So there it is predictive, but all the other situation not.
Yes, thank you. Dr. Marcus, you passed more than near. We have 20 minutes only to pass 3 hours after our start. If you don't want to complete, it's okay.
No, we have only another 20 slides. We will make it. No worries.
Okay.
Let's move on.
Thank you.
Okay.
Thank you. So go on, sir. Go on.
Yes. Let's move then towards the treatment. And the treatment of bleeding can be for many reasons, as you see here in that scheme. But I first want to give us a little bit of an idea about the context, because hemorrhage is not equal, as you may know. It may be acute, it may be chronic. The chronic is mostly compensated, and it does not affect the anesthesia, as you may know, but maybe the ICU. But the acute, we could then distinguish between the uncontrolled and the controlled bleeding. And as you may know, in the controlled bleeding, where we go to our patients in the theater, surgeon does his work, and all of a sudden it starts bleeding. So then we shall maybe take into account the comorbidities of the patients. We can also look at the hemodynamics of the patient, so we have time to see when and what will happen here. And then we can also wait maybe on some laboratory results in order to tailor our treatment. And as you may know, in an uncontrolled situation, there will be shock. The shock may affect the coagulation again. There will be, as I told you, the lethal triad. Meanwhile, I speak also about the lethal diamond, which takes another aspect, namely the electrolytes, into consideration. And mainly there, people do something we call a blood transfusion or just a transfusion as or out of panic, if I may say it like this. Again, the definition of bleeding is very much skewed, and if you look at the massive hemorrhage in general or the PPH, there are a little bit of differences in the definition, and this makes it very difficult also to compare the studies, but also to have you a good algorithm. Some say one-time blood loss of 24 hours or more than 50% of blood volume or more than 150 milliliters per minute is a massive hemorrhage. And if you look at a PPH, this is relatively clear defined. If it is either more than 500 or more than 1,000 milliliters, depending on the mode of delivery, maybe normal. But if it's higher, it's massive, and then its hematocrit is more than 10 dropping, it may be a high blood loss. But again, this is all quite skewed, and only to give you an idea, those are all definitions of massive transfusion or massive blood loss, which is, as you can see here, very much different in their explanations. Diagnostics, we talked a bit about it, but I think we must also consider the context, the clinical context, and we did not talk enough about this, that we have to check the vital parameters, we have to see where the bleeding is happening, we have to check in the background whether there are some drugs in the game, which may be aspirin or some other effects, antiplatelet effects, some NOACs and vitamin K agonists, or we have to check whether there may be also some thrombin factor playing across, like for example in cardiac surgery again, where you have an aortic stenosis, which may be connected to some inherited thrombin, acquired thrombin defect. We may check the laboratory, as we said, but this is the minor part. How to manage? Of course, we know this. We should try to control the bleeding. If we are in the field or if we are in the emergency room, we could apply a tourniquet. Of course, the surgeon is very important here. As I mentioned already in the very beginning, coagulation factor 6, the surgical suture, is also one of the major factors of the coagulation system. We should not underestimate this. Then, of course, meanwhile, we have also some interventional factors like our radiologists. They place some balloons somewhere to include some areas of perfusion in order to control the bleeding. And then, of course, the time to hemostasis is of utmost importance. Sometimes we apply so-called permissive hypotension. This predominantly applies to trauma situations where we allow the blood pressure to be lower than 100, depending if there is an intracranial lesion or not. And what we should definitely avoid, and this is something we should come to this later, which is the lethal threat. We should avoid hypothermia, acidosis, and the exaggerated coagulopathy. Having said that, from the old days, and therefore I display this here, we were all told that we have first to treat our patients aggressively with infusion of crystalloids. Overlapping, we could then use some colloids, and then after maybe 1 to 3 liters, we could then use some RBCs, and then once we have 3 to 4 RBCs used, we should use some FFPs, and then once so forth and so forth. So this is the traditional way of dealing with it, which may be still valid in trauma situations or in emergency situations, but we must be also aware that particularly the first part, the dilution part, may actually increase the bleeding tendency much more than we want. Again, this is for me a friendly environment. So if we think about a coagulation-friendly environment, then we should think still about the good basic conditions. And this is cornerstone of all treatment, namely the good pH, the good temperature, and the proper calcium, which is also sometimes forgotten. And this is very simple, and we could apply it everywhere without any complicated measurements. We may need an ABG and a temperature probe, and that's it. And in addition to that, then we come to some substrate. So if we give some coagulation factors by whatever means, EB to FFP or whatever, then we could, of course, enhance our coagulation. Again, treat only if there is a bleeding and don't treat numbers. Correct the pH, preferentially by restoration of the circulation, as I said earlier. Correct the temperature wherever possible. Correct calcium amount. Target an hematocrit of 25 and above, because, as I said to you already, Coagulation is affected by the amount of platelets, red cells circulating. In that sense, it will be very effective. Use tranexamic acid, and this will come later in a slide. And avoid, please, HES products. They have actually no good place in trauma resuscitation, and I would also avoid them in general because they have a lot of unwanted side effects, apart of potential coagulation effects. Coming to antifibrinotics, again, it's common knowledge. CRASH trial, CRASH-2 trial, and then the women trial showed us that the use of tranexamic acid could be beneficial if we apply it early in the scene, maybe preventatively. Maybe we could repeat it after the first gift, which should be done in 1 hour after trauma. And then we should go on. Why is it important? As I showed you in the first part of this presentation, of today's presentations, that fibrinolysis kicks in quite earlier. And if we inhibit this, we actually inhibit at the end of the coagulation, which means once there is a clot, it will be not broken off so quickly. Sorry. So in that sense, it may be good to think about this, particularly as the side effects are relatively less. Although in lots of literature, it is said that there is an issue with potential seizure-producing effects. This is dose-depending, and if you stick to lower dosages, about 1 to 2 to maybe 3 grams, everything below 5 grams is still okay. Coming to that, to speed it a little bit more, we have 2 major ways to do. One is the good old military or American way to do, which means a 1-to-1 ratio-based, a panic-based, or a massive transfusion-based ratio. In uncontrolled situation, this may be the first way to start. And we could either use normal blood products, or in the situations like a military situation, as we discussed earlier already, it could be done with whole blood. Once again, we will never, and this is the next slide, we will never reach to the quality of whole blood by mixing the products together. But in Europe, particularly in Austria, therefore I display this, they came to the conclusion that if you are treating quite aggressively, quite early on the scene with coagulation factors, with concentrates, then you could have an individualized approach which could stop bleeding early and avoid the complication which result after dilution and hypothermia and all this kind of stuff. So ideally, we should try to avoid coagulopathy. We could use fresh whole blood, but there is the risk, as we said, infection and availability. We could try to mix our blood in a 1-to-1 ratio. Again, there is some acceptable risk of infection, but there is a risk. And the storage might be the benefit, because whole blood is, fresh whole blood particularly, is not so easy to store. But we must have into our mind, as I said, if we mix, and this is a nice study done already a long time ago, if we mix after separation of the blood this all together again, due to the anticoagulants, due to the process of separation, we will not reach same quality. We will have a lower hematocrit, we will have a low platelet count, and we will have a lower coagulation factor. And if you compare this to whole blood, which is used for therapeutic purpose, then this is also not true. This is whole blood before processing, but if you use the whole blood we use for transfusion, the coagulation factor activity is around 80%. The platelets are around 100 to 200,000, and hematocrit is maybe around normal, about 35%. So the quality is there also a bit lesser, but still better than if we mix the products together in a 1-to-1 ratio. So the ratio-based will be used in combat or in severe cases of massive hemorrhage, and we can use this as a standard there. It is shown already in the old days that if we use the early treatment package, as it was called here, then we still get some kind of acceptable results after stopping the bleeding. This might be the hemoglobin we are then reaching to. This might be an INR we are coming to, and this might be an APT and a platelet count, which is all somehow just acceptable if you think about the severity of the situation, namely an acutely, massively bleeding patient. So it is somehow, this 1-to-1 ratio, somehow comparable, but not totally, to whole blood therapy, as I told you. It could somehow prevent the development of a coagulopathy if you don't dilute the patient too much. And again, we should avoid giving too much crystalloids or any other dilution factors here. And there had been already some good reviews that it is okay, but it may result in wastage of particular FFP because people tend to give too much FFP. There is also some problem in survivor bias in those studies. So it may be that we just look at the wrong part of the studies. Patients end up in massive volume overload, and this may be, of course, of disadvantage for the elderly among our patients who may have then problems with TACOs, as it is called, transfusion-associated cardiac overload, and it may increase mobility. Coming to factor concentrates, we have recombinant factor 7A, which was already mentioned, fibrinogen, and prothrombin concentrate in our area. We have also the factor 13. However, as you in Egypt, we don't have this also in East Africa. So this is just talking about something we might like to have. Factor 7 was in the early 2000s very much propagated to use, and is coming back at the moment again. There were the major concerns that it is very efficacious maybe, but it may introduce some complications like thromboembolic complications as well, and pulmonary embolisms, but also in terms of arterial thrombotic issues. Still, it is recommended in many guidelines as the last option. If you look at the ASA guidelines, the last options in our guidelines from the ESA, it's also mentioned as last options, likewise in our European trauma guidelines. And it came back actually for the PPH treatment recently, as it was mentioned due to result of 2 studies, which we may discuss about if they're really good studies, but anyhow, it comes back. And we can use this as the minimal effective dose, which will be 90 to 140 mics per kg. But we must be aware that factor 7A needs optimal working conditions, which means good temperature, good pH, and also some substrate. Because if there is no fibrinogen, factor 7A will not work as it would work in good conditions. Having said that, fibrinogen is very much in the picture. It is actually quite early in the situation of blood loss been lowered, although fibrinogen is the factor which is has the highest concentrates, highest level and from the starting points. But due to consumption, breakdown, and changes in metabolism due to shock, it goes down rapidly. There is an unpredictable correlation with blood loss. The limits were put up recently from 1 gram per liter to do some therapeutic interventions to 1.5 to 2.0 grams, depending on which guideline you are following, either the trauma or the other guidelines. And in PPH, we do not know yet where the trigger is actually, but we know that, as I said earlier, the patients go with higher fibrinogen levels already at the start of the bleeding. So it may be that this may be a target somehow between 2 and maybe 2.5, but we don't know yet. We know that if we give fibrinogen early in the course with a quite high amount, then we could stop a bleeding effectively and quickly. These are only animal studies to show this, but there are also enough human studies meanwhile to show that this is efficacious. There is evidence, as I said, and the randomized studies are still, some are there, but they are still not 100% convincing. However, evidence seems to be good. If we look, and then the source of fibrinogen, this is important for our regions where we are looking at. I think we could not, without further knowledge, recommend to use FFP or any kind of other frozen plasma product, because the level of fibrinogen containing here is quite low. It is about 10 times lower than if we use the concentrate, and it is about, let's say, about 7 times lower if you compare this to cryoprecipitate, which is mostly available, at least in our situation, we have this available. So we should not try to give FFP to restore fibrinogen amount. We could use it, but we must be aware that we will not replenish the factors quickly. Coming to PCC, prothrombin concentrate, this replenishes actually the so-called vitamin K depending factors, so 2, 7, 9, and 10, and depending on which product you use, ferroprotein C, protein S, and antithrombin. It is mainly indicated to reverse vitamin K-induced bleeding, but it is also recommended to use this for intracranial hemorrhages for vitamin K-induced because it is quicker than if you would use fibrinogen and more effective. Fibrin, FFP, and more effective. And it is still, if you use it for other bleedings than vitamin K induced bleedings, then it is still an off-label treatment. And we should be a little bit careful because if depending on the product we use and the amount we use, we may kick our patients into a DIC, which had been shown in animal studies like Oliver Grodke's studies where they could show that the blood loss is limited in the experiment if you use 35 up to 50 units per K, but if you don't go above this, you may induce a DIC-like situation, and this is then, of course, counterproductive. So we should be a little bit aware about the dose. So the dose should be around 30 units per kg. Important is we should always, independent which approach we should use an algorithm. And this is the one we used in our unit before in the Netherlands back, ROTAM-based algorithms where we used certain ROTAM levels to see whether or not we should treat and then with what kind of method we should treat. And you see here in the very beginning some protomen because we were still concerned about protomen. Meanwhile, I would not be because we changed our practice. But there are some levels we could then treat our patients accordingly. And of course, we should only treat if the patient is really bleeding. We should not treat a number. This is a nice algorithm for massive treatment, for massive bleeding. And we see here, this is coming from Australia. And we see here that they have even those boxes. So they receive some kind of ratio-based study treatment, which we could apply in the massive bleeding patients, as I told you. But once we have a chance to do a measurement of coagulation, we should still try to get some feet on the ground to see where the problem may be and then go to more differentiated treatment. Like, for example, if we see that fibrinogen is low, we should consider cryoprecipitate or factor concentrates to give. And of course, if our ABG shows us there is a leak, deficiency in calcium, we should replenish this. Again, here, factor 7A may play a role, but only at the very last moment. And this is a massive protocol I would like to show you nearly at the end of our presentation. This is from my friend Agostini and in Italy. This is after once they detect the massive bleeding, they recommend, if not already given, tranexamic acid, which is at the moment common sense. Then they divert the patient according to the stability. If there is time to do something, they could either use transfusion or do some measurements. If there's no time, then they are more aggressive in treatment. And depending on their treatment, they first try to stabilize the patient hemodynamically by giving massive transfusion in a ratio-based fashion. And once there comes a moment to do some investigations, they do the investigations and accordingly they tailor their treatment. And once there is a stability reached, they reduce the aggressivity and they then go mainly on ROTAM-based or any other viscoelastic test, which may be also replaced by laboratory, but the caveat is here, it needs longer to be in your system, so you may not be able to have the results quick enough. And this is what I promised already to Dr. Safa. This is the algorithm we developed for our treatment back in Qatar, a ROTAM-based again treatment. So once there was a blood loss of more than 1,000 milliliters and there was blood loss ongoing, and there was some signs of shock, we gave tranexamic acid, if not already given. Then we drew some blood samples for cross-match, of course, if not done already, for an ABG and for complete blood counts. end of ROTEM, and then we treated the patients according to the ROTEM results we had, because they came up quite quickly, and mostly it was then a fibrinogen depletion, which was needed to be treated at the first instance, and there you see some limits which could give us a good trigger whether to treat with fibrinogen concentrate. We had this in Qatar, but you could also replace it with cryo if you want, or with platelet concentrate, but this was to a lesser degree needed. And if there was a defect in the extrinsic pathway, then we decided whether we should use FFP or maybe some kind of PCC, but we didn't have PCC so much in that sense. So this was more the FFP then we used to replace other factors than the fibrinogen concentrate. And then, of course, we considered and we re-looked at the bleeding situation after a while in order not to over-transfuse our patient. And I think this is the major part of having an algorithm. This brings me to the end of that part. There's 2 slides still to go. So conclusion is, if we have a bleeding, think about a surgical control, a damage control. Think about maybe minimal invasive methods to stop the bleeding. Think about maybe use a cell saver. I didn't touch on this because I think this is common sense, but this could also be applied safely in PPH. It was meanwhile proven that we can use a cell saver without being in fear of a sensitization or without being in fear of causing any kind of other problems. Then we could think about topical sealants. This is also something which comes from trauma. Then think about the innocent bystanders, create normovolemia, rewarm the patient, re-splenish if needed electrolytes and acidosis, and give early on the scene antifibrinolytics. I think this is applicable to all kinds of bleedings. And then, depending on the situation, if the patient is heavily bleeding and uncontrolled bleeding, we could consider a ratio-based approach to stabilize the patient first, which may be a 1-to-1 ratio, or like here, which was the ETP, the Danish part, the 5-to-5-5-2, which essentially is a little bit similar. Then we could think about early on the course, use factor concentrates if available, but there we should consider fibrinogen PCC. And I would rather put here in between, meanwhile, the factor 13 as replenishment before considering factor 7. And then what is extremely important, we should use an algorithm, because without an algorithm, we are lost. And this is not generally recommended, therefore I put it behind here. And by this, I would like to close the whole presentation and give you a chance, if you are still there and still awake, to ask some questions.
Yeah. Thank you, Sami and Dr. Marcus, for your endless effort this night. And it is a hot night. And some of our colleagues send me that it is a marathon, not a lecture.
Yes, but you asked for it.
So you win, of course, you are #1 in this marathon, Dr. Marcus. Thank you. This really, I have no suitable words to appreciate my gratitude and greeting to you.
Very well.
As we are a few days from the new year, I wish you all the happiness and the joyful days and all success and many happy return for you and your family. Thank you. Thank you. This is one of our most beneficial and concentrated and to the point lecture. And really, it will be a reference and in the top of our library and the platform this year. As anyone wanted to clarify any point, will come back again to this lecture and will know what he lost, what he missed. But I don't miss even 1 minute from this lecture. I am fully concentrated with you, Dr. Marcus, and I'm so happy to be your moderator today.
I'm very happy for you as moderator, because this is the best which could happen to a speaker. Thank you.
Thank you. You lost your voice because we.
Yeah, I also start coughing a bit because it was a long ride. It's a marathon.
Yeah, just to have hot lemon in this hot night with the coagulation and hemostasis. Thank you, sir. Thank you.
Thank you very much. Have a
So,
good festive season and hope to see you soon all. Okay.
yeah, I'm ready to come to Kenya to see you again.
Yeah, sure. Very good.
Thank
Thank you
you.
very
Thank
much.
you.
Thank you.
Thank
Have a
you.
beautiful evening and a good rest weekend. Bye-bye.
Thank you. Thank you. Thank you. Thank you.